Hello everyone. Very good morning to all of you. I hope I am clearly visible, audible, everything is good to go. Kindly write down in the chat box if everything is good to go. Can you write down in the chat box if I'm clearly visible, clearly audible, and everything is good to go? Very good morning to all of you. I welcome you all for today's session. So I guess yes, we can start ahead. Wait a while, just a second. Yes, I think everything is good to go. I can see the comment box. You can write down. Yes, thank you. Thank you so much for confirmation. Thank you. So, very good morning to all of you. I welcome you all for today's session. I am Dr. Priyanka Sachdev here, and today we all are gathered here to continue our pharmacology rapid revision. So, we are going to continue pharmacology rapid revision. Here you can see. Just a second. Just a second. Give me a second. My pen is not working. Let me see what's the issue. You have to give me a second to fix it. I think it's working now. Yes, I'm really sorry. So let's continue with the pharmacology rapid revision. Yesterday we have already started the marathon, the rapid revision of pharmacology, and we have completed entire general pharmacology yesterday. We have completed pharmacokinetics as well as pharmacodynamics. And today is the big day because today we are going to cover the systemic pharmacology, right? So let's start it. So this is the orientation for today. So today we are going to start first of all with the renal system. I will teach you diuretics here. Then we will move on the cardiovascular system. Then we will move on the central nervous system. Then we will move on the autonomic nervous system. Then we will move on the respiratory system. So in this sequence, we are going to cover the systems one by one, all the important drugs, all the important PYQs, MCQs based on that. So you will have a rapid review and the crush of all the drugs, all the pharmacology together. So if they are not wasting any further time, I must continue, I must start. So let me start with the first system for today. And in the end today, after completing all these, I will come on the antimicrobial drugs. Antimicrobial drug is a very big chunk. I hope we can cover it today. If we couldn't cover it today, we will schedule one more session in which we will cover it. Okay, so let's start with the renal system. The first system for today is renal system, where I want to teach you diuretics. Believe me, you get many questions from the diuretics, and they are really the brain teasers, you know. So let me tell you the renal system, all the important drugs here, the diuretics mainly. Okay, so if you want to understand the renal system, you must have an overview of the renal system, the anatomy, the histology. Then you will have a better understanding of the pharmacology. So we know humans have a pair of kidney. In renal system, we all have a pair of kidney. Inside each kidney, there is 1 million nephron. Nephron is the structural and functional unit of the kidney. Each kidney contains 1 million nephrons. So humans have two kidneys, one right, one left. So there are 2 million nephrons present in the human. So let me tell you the parts of the nephron. If you want to understand the mechanism of action of the diuretics, you must understand the nephron first. In a nephron, we all know there are 5 parts in the nephron. First of all, there is a glomerulus. What is a glomerulus? In the glomerulus, there is a Bowman's capsule, which contain a tuft of capillaries inside that. That is Bowman's capsule. After that, there are tubules, 4 type of tubules. This is proximal convoluted tubule. This is loop of Henle. You can see this is proximal convoluted tubule. This is loop of Henle, descending limb and ascending limb. This is distal convoluted tubule. You can see DCT. And this is collecting tubules. You can see this is collecting ducts or collecting tubules. These all together known as tubules. These are together known as tubules. I hope you are getting it. So this is a nephron. So you can see humans have a pair of kidney. Inside each kidney, there is 1 million nephron, and these are the 5 parts of the nephron. Everyone can understand. Now, you can see from the renal artery, this is the afferent arteriole coming inside. Afferent arteriole. Afferent arteriole come inside, form a tuft of capillary inside the Bowman's capsule, and after that it leaves as efferent arteriole. It leaves out as efferent. So afferent arteriole is coming, forming a tuft of capillary and leaving out as efferent arteriole. After the efferent arteriole comes out, it forms a capillaries. It form a bunch of capillaries around the tubules. It is known as peritubular capillaries. So let me show you here. You can see this is a sketch diagram of a nephron. You can identify the parts of the nephron, right? Yes, you can see the tubules. Where are the tubules? Okay, This one is PCT, proximal convoluted tubule. This one is loop of Hanley. You can see descending limb, ascending limb. This one is distal convoluted tubule, DCT. And this one is collecting ducts. Collecting ducts are there. Now the entire tubules, I'm not talking about the glomerulus, I'm talking about the tubules. All the tubules are lined by epithelial cell. You can see the green color cells, the epithelial cells. Okay, these are known as tubular cell or epithelial cell. Can you see the green color cell? So from the lumen, these are illuminated structures now. The lumen inside is lined by these cells. You have to understand these cells if you want to understand the mechanism of action of the diuretics. I'm starting from the scratch. Okay, so please see, this is a nephron which is present in the kidney. In each kidney, 1 million nephrons are there. Okay. In the nephron, you can see the parts of the nephron. You can see the tubules in the nephron. You can see PCT, loop of Hanley, DCT, collecting duct. They all are lined by the green color cells I have drawn. These are known as epithelial cell or tubular cell. Okay, you can see it completely. Now, you see here what I have drawn. This is the afferent arteriole coming. Afferent arteriole. Can you see? This is the afferent arteriole entering inside the Bowman's capsule, forming a tuft of capillary. Can you see? Forming a tuft of capillary, multiple tuft of capillary, multiple tufts of capillary, then leave out. It leave out as efferent arteriole. So afferent arteriole is coming, forming a tuft of capillary and leave as efferent arteriole. After leaving, this efferent arteriole form a bunch of capillary over the tubules. It is known as peritubular capillaries. It is known as peritubular capillaries. You are getting my point? So please understand it very well. Okay, this is, now can I draw this simply? So these all tubules, can you see? These all tubules are surrounded from all the sides by capillary. Very dense network of capillary. Can you see the red color capillaries are there, which are coming out of the efferent arteriole? So what I am saying, see it again here, see it again. So I am saying this is the afferent arteriole coming here. Afferent arteriole. It is coming here. Look at the arrow. It is coming. It is entering inside the Bowman's capsule. After entering, it forms a tuft of capillary like this. It forms a tuft of capillary like this, multiple capillaries. After that, it leaves out. It leaves out in the form of the efferent arteriole. So afferent arteriole is coming, forming a tuft of capillary and leave out as efferent arteriole. After leaving out, it forms a bunch of capillary over the tubules. Okay, bunch of capillaries. It is peritubular capillaries, and they surround the tubules from all the sides, everywhere, 360 degree, all the sides. Okay, so it is looking like this. This is the simplified diagram where this is the master diagram where I will teach you all the diuretics. Now, what this master diagram is showing to you, please concentrate. I request you. Okay, now you can see the green color cells. What are the green color cells? I told you the green color cells are lining the tubules. By tubules, I mean PCT, loop of Hanley, DCT and collecting duct. They all are lined by the green color cells. Okay, these are tubular cells or epithelial cell. So see any tubular cell, one of them, any, say this one, okay, say this one, any one of them. So on one side of the tubule, there is lumen which contain the urine. There is lumen which contain the urine. And on other side of the tubule, there is blood. You are getting my point, huh? So let me show you here again what exactly is happening. Last time I'm telling you, listen, if you understood this diagram now, the complete next 30 minutes will be worth for you understanding. But if you don't understand this diagram, the next 30-40 minutes are useless sitting here, because you don't understand diuretics if you don't understand the basic structure of a nephron. Okay, now please understand. So this is the afferent arteriole. This is the afferent arteriole coming from the renal artery. Can you see afferent arteriole? It is coming here and forming a tuft of capillary and leaving out as efferent arteriole. Please understand. Now the blood which is coming here from the afferent arteriole, whatever substances which are supposed to be excreted out in the urine, they will filter out. They will get filtered. They will get filtered and they will accumulate here. They will accumulate here in the Bowman's space. They will accumulate here in the Bowman's space. This is known as urine. I can call it filtrate, but later on we will call it urine. So urine is formed like this. From the blood, all the substances which are supposed to be excreted out in the urine, they will get filtered out and they will accumulate in the Bowman's capsule. The remaining things of the blood will go away in the efferent arteriole, which are not supposed to get excreted. They will go away in the efferent arteriole. So blood is coming via afferent arteriole whatever substances which are supposed to get excreted, they get filtered out, and the remaining things will go out in the efferent arteriole. So here there is accumulation of the filtrate. Better to call it filtrate. We will call it filtrate. For your understanding, I am saying urine. We will call it filtrate. But later on, many exchanges takes place. Finally, after collecting that, we call it urine. After collecting that, there is no exchange. So finally, it is urine. But for your understanding, you can call it urine also. So I am saying that, see this diagram. Now see this diagram. I am saying that, see any tubular cell, any of the tubular cell. Let me highlight one of the tubular cell, the green color cell. So can you see the green color cell? This green cell, any. So on one side, they have the lumen. Okay, let me show you the lumen. The lumen, this is the lumen. It contains the urine. So on one side of the tubular cell, there is urine. Always there is urine. This is complete urine. On one side, there is lumen. The lumen contains the filtrate. The lumen contains the filtrate. The lumen contains the urine, which is coming from the Bowman's capsule. Okay. And on other side, they are surrounded by the capillaries. On other side, they are surrounded by the capillary which contain blood. So see the green color cell in between. On one side, there is urine, and on other side, there is blood. I want thumbs up from each and every one of you if you got this point. So there is an epithelial cell or tubular cell in the center. On one side, there is urine. On one side, there is blood. Let me show you this. This is the master diagram. Students don't have understanding ki diagram aaya kahan se. Now I will explain you the 5 type of diuretics in this diagram only. Hana, you can see a green color cell. What is that green color cell? This green color cell is tubular cell, the tubule cell. It can be any tubular cell, PCT, DCT, loop of Henle, collecting duct, anyone. On one side, there is lumen, and the lumen contains urine. On other side, there is capillary, and the capillary contains blood. So you can imagine this cell, the central cell. Can you see this cell? This cell can be any of this cell. Any of the cell, the green color cell. Everyone got it? Anyone having any confusion, please ask it right now. Please ask it. What's the use of the tubular cell? Dr. Doom, I will come on that. I will come on that. So you have understood this diagram. Dr. Doom, you understood this diagram. The use I will tell you later on. But you understood this diagram. Okay. So this is the diagram of the nephron. I'm saying it from the beginning. Chalo, start karo. Humans, we all have a pair of kidney. 2 kidneys, one right, one left. Inside each kidney, we have nephron. The diagram is in front of you. How many nephrons are present in each kidney? 1 million. 1 million here, 1 million here, approx. So we humans have 2 million of nephron. This nephron is the structural and functional unit of the kidney. Okay. In the nephron, there are 5 parts. You can see the 5 parts in front of you. Glomerulus, PCT, loop of Henle, DCT, and collecting tubule. Apart from glomerulus, remaining all together known as tubules. The tubules are lined by, the tubules here you can see, the entire, these all are tubules. The tubules are lined by tubular cells. You can see the green color cells, tubular cells. The complete tubular cells, or you can call them epithelial cell. Epithelial cell, tubular cell, they are same. They are same. They are the lining cells of the tubules. The 4 type of the tubules, PCT, DCT, loop of Henle, collecting duct. Now you can understand the glomerulus. No. In the glomerulus, this is afferent arteriole which is coming. Can you see? After coming, it is forming a tuft of capillary and leaving out as efferent arteriole. Now, whatever substances which are supposed to get excreted in urine, they will get filtered out. They will get filtered out here. So from the capillary, whatever substances want to get excreted, they will filter out here and accumulate here, and they will form the urine. And remaining things will go in the efferent arteriole. So the urine, here in the lumen, urine is present. In the lumen, this is urine. So see any cell. Any cell. On one side, it's urine containing lumen containing urine, and the efferent arteriole will form a capillaries. The efferent arteriole will form the capillaries around the tubules. It's like that. A bunch of capillary, dense capillary. So basically the diagram is like that. Okay. So this is a epithelial cell. On one side, there is urine, and on other side, there is blood. If everyone got this diagram, I can move ahead. Everyone means each and every one of you. Everyone got this diagram. So this is an epithelial cell of the nephron. It can be a cell of PCT. It can be a cell of DCT. It can be a cell of loop of Henle. It can be a cell of collecting duct. It can be a cell, anyone. But for all these cells, on one side, you can see the yellow color urine. On other side, you can see the red color blood. So this is the master diagram. Now you got it. Let's start the chapter diuretics. Now you are ready to start the chapter diuretics. Let's start it. Okay. What are diuretics? What are the drugs diuretics? Diuretics are the drugs which are used for symptomatic relief of edema. Edema anywhere in the body. Edema is simple language. It is known as swelling. Swelling anywhere on the body. In Hindi, it is known as sujan. Anywhere on the body, anywhere from head to toe. It can be external, it can be internal, it can be pulmonary edema, it can be any hepatic edema, it can be any internal organ also, it can be external also, on the face, on the legs, anywhere. So whenever a patient is coming to you with such a complaint, edema, swelling, sujan, the meaning is the same. It is for symptomatic relief. We give the drug diuretics. Diuretics are for symptomatic relief, not for cure. Just say, for example, fever. Fever is not a disease. Fever is symptom. It's a symptom. It is indicating some underlying disease. If someone is coming to you, doctor, I'm having fever, it means the person can have dengue, the person can have malaria, the person can have COVID, the person can have typhoid, the person can have multiple things. The fever is an indication that the person is having some underlying disease. So what we will do? So first of all, we have to subside the fever by giving paracetamol. Paracetamol is a symptomatic relief of fever. So you give the paracetamol, the fever will subside for the 6 hours. Okay, 6 to 8 hours. Again it will come. Again it will come. Unless and until you will not cure the cause. So whatever is the cause, you have to treat that cause so that fever do not come. In the same way, I am saying edema. Edema is not a disease. It's a symptom. It's a symptom indicating some underlying disease. If the patient is coming to you, doctor, I'm having swelling somewhere. Swelling here, there, here, anywhere. Okay, I'm having swelling any part of the body. It is indicating some underlying disease. Maybe swelling can occur. If you have read pathology, the swelling occurs in cardiac disease. The swelling occurs in the hepatic disease. The swelling occurs in the renal disease. The swelling occurs in the inflammation. The swelling occurs due to sodium and water retention. So cause can be anything. We don't know. But for the symptomatic relief, we can give diuretics, so that meanwhile we can do the investigation and find out the cause and cure the cause. Unless until we don't cure the cause, the swelling will come again. But diuretics are for symptomatic relief of edema. Okay, you got it. No, we got it. It is for symptomatic relief for the edema, the diuretics. We got it. But how does they work? What does they do? How does they give symptomatic relief in edema? In edema, what is edema? Edema is excessive accumulation of fluid in the body, in the interstitial space. Human body is made up of organ. How many organs we have? We have many, multiple organs, hundreds of organs in our body. Imagine this is any of the organ. These are the cells of the organ. This is brain, heart, kidney, okay, liver, spleen, any organ. These are the cells. The space between the cells is known as interstitial space. This space. Normally, this space is dry in all the organs. This space is dry. This space do not contain any fluid. But if this space contain the fluid, the organ will swell, and that will lead to swelling or edema. So what is the definition of edema? What is edema? Edema is excessive accumulation of fluid. Fluid in where? Fluid in interstitial space. Interstitial space. This is edema. Edema. So if you are giving diuretic to this patient, diuretic, so whatever this extra fluid is there, the yellow color extra fluid, that will be excreted in the urine, and the patient will have symptomatic relief. Symptomatic, I am saying. It is not a cure. Please understand. It's symptomatic temporary relief. Again, it will occur if you don't cure the cause, like fever. I hope you are getting it. Okay. So this is diuretic. So what is the meaning of the diuretic? They excrete two things in urine. Number one, sodium. Do you know the rule? Jahan sodium, wahan water. Wherever the sodium go, water will follow that. Yes or no? So it excretes sodium in the urine. So sodium will take water also. Sodium and water, two things in the urine. So any drug which excretes sodium plus water in the urine, such a drug is known as diuretic drug. Understand from the basic. So this is the definition of diuretic. How many of you got the definition? What's the definition of diuretic, people? Diuretic are the drugs which excrete sodium and water in the urine. Any drug which excrete two things in the urine. Sodium. If sodium is going, of course, water will go. So sodium as well as water. Obviously, if sodium will go, water will also follow. Sodium and water both are excreted in the urine. With any drug. Such a drug is diuretic. Now come on the classification. Okay, how many categories we have? We divide the diuretics in three categories. What are the three categories we are having? So diuretics are divided in three categories. High ceiling. High ceiling means strong. They are very strong. They are given in emergencies, or they are very strong. Okay, high ceiling. Okay, the second is medium efficacy diuretics. And the third is weak diuretics. There are three categories. The name itself indicates the names are based on their efficacy, how efficacious they are. High ceiling, they are very strong. And moderate, they are moderately strong, medium efficacy. And weak are weak. Weak are further divided in three categories. So total 5 categories we are having. Okay. In the high ceiling, we are having loop diuretics. Loop diuretics known as Lasix. Loop diuretics or Lasix, one and the same thing. Loop diuretics or Lasix in the high ceiling. I will tell you the name of the drugs also. In the medium efficacy, we are having thiazides and thiazide-like drugs. I will tell you the name of the drugs also. In the weak, we are having 3 categories. What are the 3 categories we are having? Number 1, carbonic anhydrase inhibitor. There is an enzyme known as carbonic anhydrase. They are the inhibitors of carbonic anhydrase. Number 1. Number 2, potassium sparing diuretics. Because the loop diuretics as well as thiazide, there is a side effect, they lose potassium in the urine. So patient have a risk of arrhythmias and all. So they lose the potassium. But here, the potassium sparing will not lose the potassium. So it's potassium sparing diuretics. Okay. And the third and the last category we are having here is the osmotic diuretics. They osmotically take water with them. So total 5 category. Now I will tell you a mnemonic. Please understand. Take one letter from the first letter of each of them. I want to make a mnemonic. So instead of calling the loop diuretic, call it L. Instead of calling thiazide, call it T. Instead of calling carbonic anhydrase, call them C. Instead of calling potassium sparing, call them P. P for potassium sparing. And instead of calling osmotic completely, call them O. Call them with first letter because I want to frame a mnemonic, no? That's why. So if I say L, I mean Lasix, loop diuretics. If I say T, I mean thiazide. If I say C, I mean carbonic anhydrase. If I say P, I mean potassium sparing, P for potassium. And O means osmotic diuretics. Take them one word. Now, drugs you have to learn. It's your homework. You should learn the drugs in each category, okay? Now, for example, in the loop diuretics, in the Lasix, we are having 3 drugs. Okay, furosemide, bumetanide, torsemide. Here, the prototype drug is the furosemide, bumetanide, torsemide. These are the 3 drugs in this category. In the thiazides and thiazide-like, we are having many drugs like hydrochlorothiazide, hydrofluothiazide, flumethiazide, benzathiazide, chlorthalidone, metalazone, zipamide, indipamide, clopimamide. So you have to learn the name of the drugs. Now coming on the weak. In the weak, we have 3 categories. Carbonic anhydrase inhibitor is only one, acetazolamide. Osmotic diuretics are the sugars. They are the sugars like mannitol, glycerol, isosorbide. And potassium sparing, we divide them in 2 categories. One are aldosterone antagonist and one are renal epithelial sodium channel inhibitors. So aldosterone antagonists are spironolactone and eplerenone. And sodium sodium channel inhibitors are amiloride and triamtan. So basically you have to learn the classification. You get many questions on the classification. You want to have a look how many questions you get from the classification. Very simple question. Have a look here. Have a look. For your example, these are your PYQs. These are the MCQs already asked in your competitive exams, the medical entrance exams. Okay. Which of the following is an aldosterone antagonist? No, this question is based purely on the classification. You know the classification, you can tell me the name of the drug. So I'm asking one of the potassium sparing diuretic. And which of them is the aldosterone antagonist? Is it eplerenone? Is it deoxycortisone? Is it phenoldepam? Or is it furosemide? What is the correct answer? Please write down. What is the correct answer? Yes. Yes. Absolutely right. The correct answer is eplerenone. You all are right. You can see here eplerenone is aldosterone antagonist, which is one of the potassium sparing diuretics. So if you know the classification, half of the things are clear. Okay. The second question, which of the following is a high ceiling diuretics? High ceiling, the high potency diuretics. I told you 3 drugs there. So which of them? Is it furosemide? Is it spironolactone? Is it acetazolamide? Is it thiazide? All of them are diuretics only. You have to tell me the category. So the thiazide belong to thiazide category. Thiazide-like drug. Acetazolamide belong to carbonic anhydrase inhibitor category. Spironolactone is one of the potassium sparing diuretics. It's one of the aldosterone antagonists. Furosemide is the high ceiling loop diuretics or Lasix. So correct answer is A, and you all are right. Absolutely right. So my point is that learn classification. In your entire pharmacology, somewhat 35 to 40 classifications are ultra important. You have to learn all of them. So my suggestion to all of you, take printout of these 40 classifications. Print out. So if you wish, I can share you the PDF. We are having the PDF like this. the 40 pages, है ना, 40 page PDF like this. Not long. This is the classification of the diuretics. In the same way, the anticoagulants, in the same way, the cholinergic, anticholinergic, adrenergic, anti-adrenergic. Likewise, you should one page, one classification. So likewise, 40 classifications are there in your syllabus. Please take the printout. I mean, print out one-sided, not both-sided, and stick it on your wall. Wherever you stay on your wall, stick them. So aate jate, whenever you are getting up and passing, you just have a look on those one by one. So looking at them again, it will fit in your mind that which drug belong to which category. So first of all, if I say the name of any drug, most of the students don't even belong to which category it belongs, to which system it belongs. You should understand the system. This is a drug of CVS or CNS or GIT. And after that, in further category, how does it belong? So what is that drug? If you understand that, जब तक drug को पहचानोगे नहीं, answer कैसे करोगे? If you don't recognize the drug, how you can answer it? First thing is the recognition of the drug. For recognition of the drug, you must know the names of the drug, all the drugs, including the latest drugs. So please learn the name of all the drugs. For that, learn all important classification. This is the best way you can do. If you try to mug them up all together in one day, it's impossible. Technically, it's impossible. Okay, so please take the printout, stick it on your wall, उसको देखते रहो. Whenever you are solving any MCQ, any drug is coming and you are unable to recognize, have a look in your charts. The 40 charts are in front of you, no? On your wall. Search that drug where it is. Once you will find it, it will fit in your mind. Yes, this drug belongs to this category, and you can solve the question easily. Okay, so this is a way you can go. Anyways, chalo, let's move ahead. So the question from the classification in the pharmacology, 30 to 40% question come from the classification itself. If you just learn the classification, 30% questions are in your pocket, है ना? Remaining 70% based on the mechanism of action, adverse effect, uses and concepts. But 30% are purely based on classification. So please, the step number 1, learn classification in pharmacology, without which you cannot understand the pharmacology. Okay, anyways, that was just a suggestion. To follow or not, it's your choice. Okay, chalo. Let's move ahead. So coming on the next question. Which of the following is a carbonic anhydrase inhibitor? There is only one drug which is carbonic anhydrase inhibitor. What's that? Read the 4 options. Is it acetazolamide? Is it spironolactone? Is it benzythiazide? Or is it clopamide? What is the correct answer? Yes, of course, the correct answer is acetazolamide. Only one of them is carbonic anhydrase inhibitor. That is acetazolamide. So learn the classification. Now, the next thing, what I taught you till now, what I taught you? I taught you the classification of the diuretic. I told you the definition of diuretic and I told you the classification of diuretic. We divide diuretic in 3 categories. High ceiling diuretic, okay, moderate, medium efficacy diuretic and weak diuretic. The high ceiling are known as loop diuretics, loop or Lasix. The medium one are known as thiazides and the weak one are further divided in 3 categories. What are the 3 categories? Carbonic anhydrase inhibitors, potassium sparing diuretics and osmotic diuretics. So tell them with one word. Say the one word now. I will tell you the mnemonic. Loop diuretics I will indicate by the word L. L for loop. Thiazide I will indicate by the letter T. T for thiazide. Carbonic anhydrase by the letter C. Potassium sparing by the letter P. And osmotic by the letter O. So if I say this letter, you must understand what I am saying. Okay. Now tell me the mechanism of action. I mean site of action for all 5 together. So all of them act on the kidney. Of course, they all are diuretics. Come on. They all are diuretics. So they all act on human kidney. Inside the human kidney, they act on nephron. But in a nephron, we are having 5 parts. There are 5 parts in the nephron. Let me draw the nephron. So you can see this is glomerulus. This is PCT. Everyone knows the diagram of nephron from your school time. This you have learned in your 8th or 9th standard. So first of all, there is glomerulus. Then there is PCT. Then there is loop of Henle. Then there is DCT, distal convoluted tubule. And there is collecting tubule. So you don't have to learn the sequence. I assume you know the sequence. So this is glomerulus. This is PCT. This is loop of Henle having 2 limbs. This is descending limb of loop of Henle. This is ascending limb of loop of Henle. This is DCT, distal convoluted tubule, and this is collecting duct. If you know the sequence, learning the mechanism of action or site of action of the 5 type of diuretics is very easy. You have to learn the mnemonic. None of the diuretic act on glomerulus. Okay, the 5 diuretic act on the tubules, all 5. So on PCT, carbonic anhydrase inhibitor act. C. Okay, on descending limb of loop of Henle, osmotic diuretic act. O. On ascending limb of loop of Henle, loop diuretics act. L. On DCT, thiazides act. T. And on collecting tubules, potassium sparing act. P. So my mnemonic is cold P, C-O-L-T-P. I will say it again, don't worry. So what is my mnemonic? What is my mnemonic? My mnemonic is C-O-L-T-P, cold P. You know the sequence of nephron. In the nephron, my sequence is PCT, descending limb of loop of Henle, ascending limb of loop of Henle, DCT and collecting duct. So in this way, I can make it out that which diuretic is acting where. So instead of learning, make a mnemonic. It will be easy for you. So you know the sequence in a nephron. First of all, imagine the diagram of nephron in your mind. Close your eyes and imagine the diagram. First of all, after glomerulus, what we have? After glomerulus, we have PCT. Then we have loop of Henle ka descending limb. Then we have loop of Henle ka ascending limb. Imagine the diagram. Then we have DCT and finally we have collecting duct. If you know this sequence, I guess everyone knows. Just learn the mnemonic COLTP. Done, done. We are done, done. Got it? My point is carbonic anhydrase inhibitor acts on PCT. Osmotic diuretics acts on descending limb of loop of Henle. Loop diuretics acts on ascending limb of loop of Henle. Okay. What is this T? Thiazides acts on DCT and potassium sparing, all potassium sparing. We have two types of potassium sparing. Okay. Both of them acts on the collecting duct. So it will be easy for you to understand. You know the sequence. You don't have to learn if you know the diagram of the nephron. You know the sequence. Only thing you have to learn the sequence. For learning the sequence, make a mnemonic and learn that. You get many questions on that. People, believe me. How many of you got it? Acha. How many of you didn't got it? Everyone. So you can write down here COLTP. So see, I'm writing C here, O here, L here, T here, and P here. I hope you are getting it. Which diuretic acting on which portion of the nephron, and the same thing is written in front of you. If I don't give you this mnemonic and ask you to mug it up, to learn it up, you will find it difficult and in the exam you will be highly confused. But with the help of mnemonic, it will be super easy. Now, shall I show you the questions based on this mnemonic? Yes. So we will see some questions. Read the question. Tell me the answer. Read the question. What is the site of action for furosemide? First of all, it's a double step question. First, you tell me furosemide belong to which category? COLTP में से कहाँ आता है? Where it is coming? COLTP. So where it is coming? Furosemide is what? Is it carbonic anhydrase inhibitor, osmotic diuretic, loop diuretic, thiazide or potassium sparing? It is loop diuretic. We all know. Furosemide, bumetanide, torsemide, they are loop diuretic. Hai? So where they are acting? Now tell me the sequence where they are acting. So this one is PCT. This one is loop of Henle ka descending limb. This one is loop of Henle ka ascending limb. So they are asking for this. So my answer is loop of Henle ascending limb. Where it is? Just find out. Loop of Henle ascending limb. Okay, I guess everyone know the descending limb is thin and the ascending limb is thick. I guess everyone know. So go with the thick ascending limb of loop of Henle. So this is how you can make it out. So we are talking about this. Give me a thumbs up. Everyone give me a thumbs up. Okay. Anyone have any confusion till now? You get the questions like that. So first of all, you must know the class. If you don't know furosemide belong to which category, there is no need of learning this mnemonic. तुम्हें पता ही नहीं है furosemide इन पांचों में से किधर आता है तो mnemonic का क्या sense है? First you learn the classification. Step number 1. If you don't know A, B, C, D, there is no need to learn CAT, CAT, BAT, BAT. No need. If you don't understand the basic, the same way. First of all, learn the classification. Then only you learn the concepts behind that. Okay, chalo. So we will play KBC now. Will you play with me? Fastest finger first. Okay, in the KBC, we select the participant with fastest finger first now. So let's see who is the fastest finger. Who's the fastest finger among all of you? The audience who are live. Right now we will play it. Have a look here. What I'm asking, first you understand the question, then I will give you the options. First, you understand the question. So arrange the following diuretics according to their site of action from proximal to distal portion of the nephron. So you have to arrange them in a sequence. I will give you 4 options A, B, C, D. So you have to arrange them DBCA, BCDA, DBAB, whatever. You have to arrange them from proximal to distal portion of the nephron in a sequence they act. So the one who is acting here will be first, the one who is acting here, then here, then here, then here. You have to arrange them in a sequence. Shall I give you the option? Are you people ready? I will give you only 10 seconds. Let's see who is first. Okay. The one who is first, please write down your answer in the comments. Okay. I will see who is the first. So the four options are in front of you. Just a second. Let me erase it. You will have a clear view. Okay. So the 4 options are in front of you. You can see. The 4 options, option A is triamtarin, option B is hydrochlorothiazide, option C is acetazolamide, and option D is bumetanide. Apply the mnemonic COLTP, C-O-L-T-P, and apply it here and arrange them in a sequence. What is the correct answer, people? What is the correct answer? I'm asking. Yes, what's the correct answer? No one till now. Oh my God. I think there's a lag in the comment section. So it's Sarvanthi. Sarvanthi Kodli is saying CDBA. I guess, let me see, you are right or not. I'm not sure. So let's see. Let's see who's first to answer and who's correct also. Okay. So first of all, you have to tell me the categories they belong to. So I guess everyone know tramtarin. Where is the tramtarin drug is belonging? हाँ ट्रामटेरिन कहाँ पे बिलोंग करता है? Yes, the correct answer is CDBA. You all are right. The correct answer is CDBA. Where is tramtarin? Tramtarin is a drug belonging to which category? Acetazolamide is carbonic anhydrase inhibitor. Bumetanide is a loop diuretic. Hydrochlorothiazide is a thiazide. And tramtarin is a potassium sparing diuretic. So I have written one letter based on their category they belong to. And I know the mnemonic COLTP. So first of all, there is C. O is not given. O, then L, then T, then P. So answer will be C, D, B, A. And all of you are right. Okay, absolutely right. So this is a way you can get tricky questions. Now this question is double step question. First of all, the examiner is judging you that whether these drugs belong to which category in the classification you know or not. So we have judged that whether which student know the classification, which student don't know the classification. Second step, the one who know the classification, whether they know the mechanism of action, the site of action, yes or no. We have judged that also. We have asked you to arrange them in a sequence. The student who know both, those students only can answer it correctly. Okay, so this is the way you should go. I hope you got it. Give me a thumbs up. Can we go ahead? Can we go ahead? Okay, chalo. So coming on the drugs, individual drugs, we have seen the classification and we have seen the site of action. Now, can I tell you the 5 categories? Huh? So I will tell you first of all loop diuretics, then we will see the thiazides. These are carbonic anhydrase inhibitor, these are potassium sparing diuretics, and these are osmotic diuretics. Since the time is limiting and I have to take entire systems of pharmacology today, not only this system, I will take these 2 only. The remaining 3 you can do by your own. But this is a way to study pharmacology. Entire pharmacology you can convert into master charts. I call them master charts. Don't read pharmacology page by page. No, you will forget. It's a volatile subject. You read, you understand, it evaporates, and you forget. So this is a process you follow. So you will forget everything if you read the pharmacology page by page. No, not at all. This is not a way to study pharmacology. You must study pharmacology in this way. I call them master charts for all the drugs in entire pharmacology. Chapter by chapter, convert them into master charts. Four things you have to see for all the drugs. For all the drugs, you should know the name of all the drugs belonging to that category. Now, in the loop diuretics, how many you know? I know 3. Furosemide, bumetanide, acetazolamide. I will write down here all 3. Whatever drugs you know in that category, you should write it there so that you can recognize the drug. Number 2, maximum question comes from mechanism of action in your exam. So you must understand the mechanism of action with the help of the videos, with the help of animation, with the help of diagram. I will show you. But here in one line, you have to summarize it. Once you have understood it, in just one line, you can summarize it. After that, for uses, most of the time use mnemonics, as many as you can. And for adverse effect, use mnemonics, as many as you can. After understanding, use the mnemonics. So here I will try to give you maximum mnemonics in the uses and in the adverse effects. Mechanism of action is something you have to understand. I will show you videos, animations, and help you in understanding. And the drugs, you have to mug it up. So this is a way. Now, if you convert entire pharmacology like this, now imagine that tomorrow is your exam. Whatever exam you are targeting, the next few days you are having your exam, you are taking your master chart copy, having all the master charts of entire pharmacology in one copy. Hardly you are having 40-50 pages. One by one you are flipping the pages and you are just revising the entire categories. So all anticoagulants on one page, on cholinergic drugs on one page, on all anticholinergic on one page, all diuretics on one page, all antidiuretics on one page. So page by page you are just revising the important concepts. Entire pharmacology can be revised in just 2-3 hours, 3 to 4 hours. I'm not exaggerating, not at all. Anyone can do so. This is a proper way of doing. Okay, reading, studying pharmacology. Anyways, let's go ahead. So in this way, the master charts I will give you. So let's start the first category, loop diuretics. Can I start? I will fill it with you to show you how to go with that. So let's start with the loop diuretics. Can I start the loop diuretics? Yes. So first of all, you tell me the drugs belonging to this category, loop diuretics. Then you tell me the mechanism of action. Then you tell me uses and adverse effect. Understand that. Don't mug it up. Pharmacology is a subject to be understood. It has not to be mugged up. It's your myth that pharmacology is a subject of rectification. Not at all. So please understand all these for loop diuretics. Then the same 4 things for the thiazide. Likewise, we will go. Loop diuretics. How many drugs are there in this category? Tell me the drugs. Here we are having 3 drugs. What are the 3 drugs? Furosemide, bumetanide, and torsemide. These are the three drugs we are having in this category. Tell me the mechanism of action. Before telling the mechanism of action, tell me the site of action. In the entire nephron, where does they act? They act in the glomerulus? Say no. They act in PCT? No. They act in loop of Henle? Yes, yes. Where? Descending limb? No. They act in ascending limb? Yes. Not in DCT, not in collecting duct. So this is the site of action. You can apply your mnemonic now. Cold P. I told you cold P. So COLTP. Currently, I'm teaching you L. It is acting on ascending limb of loop of Henle. So rather than mugging up, please understand it. They act on ascending limb of loop of Henle. Now, how they cause the diuresis? Now, please see this cell. You understand this diagram? How many of you are attending the lecture from the beginning? If you are attending the lecture from the beginning, you can understand this diagram. So here I have shown you this green color cell. The green color cell is a cell of PCT. I'm sorry. This green color cell is a cell of loop of Henle, ascending limb. Ascending limb of loop of Henle. This is a cell. So basically, can you see this cell here? Please understand. Please see here. Can you see this cell I'm highlighting here? See this one. Can you see this cell? The same cell I have zoomed out and drawn on this page. Okay, the same cell which I have highlighted here. So on this cell, on one side, you can see there is lumen containing the urine. You can see there is lumen, the lumen of the loop of Henle. It contains the urine, the lumen on one side, the lumen on one side, the yellow color is the urine. And on other side, it is surrounded by a blood capillary which is having the blood. So the cell in the center. On one side, there is urine. On one side, there is blood. So basically, I have zoomed out this portion on the next page. So on this page, you can see the zoom version. Say yes. On one side, there is urine. You all can see this is the urine on one side. And this is the blood on other side. Okay. So where is the urine? You can see this is all urine. I'm talking about the lumen containing the urine. So this is urine on one side of the cell. And this is the blood. You can see on the other side of the cell. People say now, respond. You got it. And this is the cell. Cell, which cell? Cell of loop of Henle, the ascending limb. This cell. I have zoomed this portion. Now, please understand. Now, before understanding the mechanism of action of furosemide or diuretics, please understand what happens normally. In me, in you, in all normal individual. Now, in this cell, there are two membranes. This membrane is known as luminal membrane. It is towards the lumen. No? This membrane is luminal membrane. And this membrane of the cell is known as basolateral membrane, which is towards the blood capillary, basolateral. So, on the luminal membrane, there is a transporter. The name of the transporter is sodium potassium chloride transporter. Sodium potassium chloride transporter. What is the name of the transporter? See, sodium potassium chloride. It is present in me also, you also. So, me, in my kidney, in my 1 million nephron, inside the nephron, in the loop of Henle ka ascending limb, on the luminal surface, I'm having this transporter. So please locate the exact location, okay, of this transporter. Sodium potassium chloride transporter. It is present on this side. It is present in everyone. So in the urine, whatever sodium we have, whatever chloride we have, and whatever potassium we have, they will come inside this cell from this transporter from the urine. You can see the arrows normally. It happens in normal individual, me, you, everyone. Okay, so you can see what is happening now. Sodium will come inside and sodium will move and sodium will go in the blood via another transporter. It will go in the blood. What happened to the chloride? Chloride also move in the blood via another transporter. On the basolateral surface, we have sodium potassium transporter, we have chloride. So they are moving in the blood. But potassium do not move in the blood. Potassium again move out in the urine. So this happens normally. This is the fate. So sodium go in the blood, chloride go in the blood, potassium again come in the urine. That is the summary. It happens in me currently also. This moment also it is taking place in me, you, everyone. This is a constant process taking place every minute in all of us. Okay. Okay. Now imagine I'm having edema somewhere and for that I'm taking furosemide, a tablet of furosemide. Some patient, or suppose I'm having the edema. I'm coming to you, doctor, I'm having edema here. Where you will say, ma'am, we will see the cause, but meanwhile for symptomatic relief, why don't you take a furosemide tablet? I'm taking a Lasix, furosemide, loop diuretic. I'm taking the tablet from oral route. So I'm taking it. So it is going inside. It get absorbed and it go in my blood. So where is the tablet? Here is the tablet. Here is the furosemide. It come via blood. Either you give injection to me, it will also go in the blood. Or if I take the oral tablet, it will also absorb and go in the blood. So furosemide present in the blood. Okay, loop diuretic is present in the blood. So here is the furosemide. Can you see? This is the furosemide. It is present in the blood, but it cannot act from this side. So for action, furosemide have to cross the cell and come on the luminal side. So it will use a auto rickshaw. It will use a transporter. It will use a taxi, whatever you say, to cross the cell. So furosemide we take either orally or either intramuscular injection. So whether you take orally or whether you take injection, it is going in the blood. Orally also it absorb and go in the blood. Injection also it will go in the blood. So from the blood, it has to cross the cell and come on the luminal side. So for crossing, it uses a transporter. This transporter is basically in the body is for uric acid. You know, uric acid का transporter है. It transmit the uric acid from the blood to the urine so that uric acid is excreted in the urine. We all have uric acid formation in our blood. So it is excreted in the urine. So who is transmitting the uric acid from the blood to the urine? This transporter. This transporter is for uric acid. Now in the blood, uric acid is also present and furosemide is also present. So furosemide is having more affinity for the transporter as compared to uric acid. So uric acid ko dhakka marega ki you just go away. Now I am present, I will sit on this transporter. You are not allowed to sit. So furosemide is having more affinity for the transporter than uric acid. But this is a natural transporter for the uric acid. Okay. So what will happen? Furosemide will sit here. Furosemide will come on this side. But uric acid will not come. Uric acid concentration in the blood will increase. And the patient will have gout. Increased uric acid concentration, hyperuricemia. It is a side effect of furosemide. I'm just explaining the side effect. Why the patient taking furosemide for long, they can have hyperuricemia or gout. Why? This is the answer. Because furosemide for crossing from blood to lumen, the transporter used by the furosemide is a natural transporter for the uric acid. But when both are present, I'm not taking furosemide right now. So this transporter is utilized by uric acid only. But suppose today I took a tablet for the furosemide. Now in my blood, uric acid is also there. And in my blood, furosemide is also there. There is a competition between the two. Who will sit on this transporter? But furosemide is more strong. It is having more affinity. So it will push the uric acid in the blood itself and use the transporter. So that's why the patient is having gout or hyperuricemia, the patient who is using furosemide for long. Okay, for long. Okay. So the patient will, the furosemide will sit here and furosemide will come this side. After coming this side, what it is doing? It will inhibit this transporter. Furosemide block this transporter. Okay. So sodium, potassium and chloride, nothing will cross. They all will remain in the lumen. Sodium in the lumen itself, potassium in the lumen itself, chloride in the lumen itself, in the urine. They will not go in the blood. They will not go in the blood. They will remain in the blood. They will remain in the urine. Wherever there is a sodium, sodium ke saath water. Water will also not go. Water will also remain. Normally sodium was going, it was taking water along with it. But here not sodium is going, not water is going. Diuresis occur. Now, what is the definition of diuretic? I told you. At the beginning of the chapter, I told you the definition of the diuretic. What is a diuretic drug? A drug which excretes sodium and water. So is it a diuretic? Yes, it is excreting sodium and water. But unnecessarily, it is excreting potassium also as a side effect. It is excreting chloride also as a side effect. We cannot avoid it. So it is inhibiting complete transporter. We want inhibition only of sodium, but it is inhibiting chloride also, potassium also as a side effect. As a side effect, nothing will be absorbed in the blood. Nothing will be absorbed in the blood. People say, got it. So here the sodium, potassium, chloride along with water, they all are excreted in the urine. There is one more use of this transporter. What is this transporter is supposed to do? Say, ma'am, this transporter transport 3 ion. Which 3 ion? Number 1 sodium, number 2 chloride and number 3 potassium from the urine to the blood. This is transporting. Okay. 2 more ions are transported. Magnesium and calcium. So total 5 ions are transported by this transporter from urine to blood. Normally, in me, in you, if we are not taking the Lasix. Normally 5. Which 5 ion? Can you enumerate the 5 ion? Please enumerate the 5 ion. What are the 5 ions, people? Say, ma'am, sodium, potassium, chloride, magnesium and calcium also are up to a little level. All 5 are transported from urine to blood via this transporter. But imagine I took a tablet of Lasix. What will happen? If I took a tablet of the Lasix, this transporter is inhibited by the Lasix. It is inhibited by the furosemide. So none of the 5 will be transported. All the 5 will be excreted in urine. So urine contain what? Urine contains sodium. Urine contain potassium. Urine contain chloride. Urine contain magnesium. Urine contain calcium. So the concentration of these 5 will be high in the urine. Sodium jahan jahan, wahan water. Water always follows sodium. I want to excrete only these 2 as a diuresis. I know what is the definition of diuretic? Excretion of sodium and water. But these are the side effects. So the concentration of these 5 will fall in the blood. Which 5? The same 5. Sodium will fall. Potassium will fall, chloride will fall, magnesium will fall, calcium will fall, and along with that water will also fall. So all the 5 will fall in the blood. That is a side effect. And the uric acid is high. I told you this separate reason. Uric acid is high. So these are the side effects. People, these are the side effects of Lasix. Please understand in-depth knowledge. You can get many questions over that. Got it? Can I go ahead? So this is the mechanism of action. The same diagram from the KDT you can see. I tried to oversimplify this in my form, but this is the same diagram. You can see this is the same cell. This is a cell of loop of Henle, the ascending limb. Okay, you can see this is the luminal side. You can see this is the blood capillary side. Oh no, you can see the same. You can see the transporter, sodium potassium chloride transporter is inhibited. The same story is shown to you. So finally, what is the mechanism of action? Loop diuretic. First of all, loop diuretic from this side, they are traveling to this side via using a transporter of the uric acid. Okay, organic transporter. So they enter the lumen via a transporter, the uric acid transporter number 1. After coming in the lumen, they inhibit this transporter, sodium potassium chloride transporter, which is present in the ascending limb of loop of Henle. They inhibit it. Once they inhibit it, all these ions are not reabsorbed. They are lost in the urine. So since they are lost in urine, sodium is lost, water is also lost. It causes diuresis. This is the mechanism of action. Anyone who didn't understood? Anyone who didn't understood? Everyone, please give me a thumbs up if you got it. Can we go ahead? Chalo. So we are done with the mechanism of action. So what is the mechanism of action in short? In short, you tell me. Say, ma'am, loop diuretics or Lasix or furosemide, the prototype drug. What does they do? They act on loop of Henle, ascending limb of loop of Henle. They inhibit a transporter there. What is the name of the transporter? Sodium potassium 2 chloride transporter, which is present on the luminal surface of the cell. They just inhibit it, and because of which they cause the diuresis. Everyone got it? Chalo, if you got it, it's good. So coming on the uses. What are the uses of loop diuretic? There are 6 uses, and I'm having a mnemonic. I will explain also, but with the help of mnemonic, it will be easy. Number 1, hypertension. Acha, what is hypertension? Hypertension is increased blood pressure. Suppose I'm hypertensive. My blood pressure is more. So what do you want? In my blood, there should be more water or less water? You want to increase the water, increase the fluid, or decrease the fluid? What do you want? To treat the hypertension. To treat the hypertension, what do? You increase the fluid or you decrease the fluid? What's the formula of blood pressure? Let's go to physiology. Blood pressure is equal to cardiac output into peripheral resistance. Okay, if blood pressure is more, you have to reduce one of them. Cardiac output, you have to reduce. Cardiac output depends on the fluid in the body. Okay, so you have to reduce it, of course. Hana, if you reduce the fluid, the cardiac output will be reduced. Hana, so we want to reduce the fluid, not increase. We want to reduce the fluid. If the blood pressure is more, to treat the blood pressure, we reduce the fluid. Suppose I am hypertensive. Now in my blood, more fluid is present, so my blood pressure is more. So if you reduce the fluid in my body, my pressure will be less. My blood pressure will be less. Okay, so fluid is lost in the urine. Okay, diuresis decrease the fluid because they lost the fluid in the urine. So diuretics can be used as first choice drug in hypertension. So this is a mechanism of action. Okay, they decrease the cardiac output. Okay, so they are used in hypertension. Say yes if you got it. They are used in hypertension. The first use. First, I will explain you, then I will give you the mnemonic. Number 2, edema. As I explained you, imagine I'm having edema here, I'm having edema over the face, edema over the feet, edema over the complete body, anasarca, anywhere. I'm having any pulmonary edema or any edema. What is edema? It is the extra fluid in that organ. So if you want to give symptomatic relief of the edema, extra fluid is lost in the urine, so it is used as a symptomatic relief of edema also. Number 2. Okay, number 3, congestive heart failure. Congestive heart failure, you know what is congestive heart failure? The heart is unable to pump properly. Okay, so by reducing the fluid, you are reducing the workload of the heart. So heart is weak now, you want to give less workload, so reduce the fluid. So congestive heart failure, it reduces preload as well as afterload. Okay, the next is hypercalcemia of malignancy. You know malignancy, neoplasia. If you have read this in pathology, I taught you. So you know malignancy, neoplasia. In malignancy or neoplasia, sometimes metastasis occur. The bone metastasis are common in various malignancy. Whenever there is a bone metastasis, bone is made up of calcium. So suppose this is a bone and this bone is having the metastasis. So this is the mets present in the bone. So mets will lose the calcium in the blood. So such a person will have high concentration of calcium in the blood. The person who have bone mets will have high calcium in the blood. They have high calcium because the bone is degraded by the tumor, and all the calcium present in the bone will be lost in the blood. So blood have high concentration of calcium. This is known as hypercalcemia of malignancy. What's the name of the disease? It's a consequences of bone mets. It is known as hypercalcemia of malignancy. I want to treat it. I'm not talking about the metastasis. Metastasis will be taken care by the chemotherapy, radiotherapy, whatever it is, the oncology portion. But how to deal with this hypercalcemia? How to deal with this hypercalcemia? What this furosemide is doing? Furosemide is decreasing the concentration of 5 ions in the blood. Which 5 ion? One of them is calcium. Calcium is also lost in the urine. So if someone is having more calcium in the blood and I'm giving the tablet of furosemide, so the extra calcium is lost in the urine. So hypercalcemia of malignancy can also be deal with that. I hope you are getting it. Understanding is important rather than learning. I can give you a mnemonic and move ahead, ki just learn. But I'm explaining you each and every point so that it fits in your memory. Okay. Now the next is chemical intoxication. Suppose I have taken some toxin. Okay. Suppose someone is want to do suicide. I do not want to do suicide. Someone else want to do the suicide and the person have taken the toxin, poison to do the suicide. And the person is in front of me. I want to save this person. So I want to do the diuresis. So whatever toxin present in the blood that can come out in the urine. So I want to increase the urine flow in that case. So intoxication patient, we want to increase the urine flow so that the toxin excreted out in the urine and we can save the person. And number 2, BT. In one day, 1 BT is given. In one day, ideally 1 day, we do not give more than 1 BT because humans have 5 liter of blood and you are giving this extra volume as a BT. Suppose we are giving 20 BT in 1 day in case of severe blood loss, severe accident, or severe surgery, blood loss. So here volume overload can occur. No? The person can have a volume overload and the heart can go in failure. We cannot do so. So if you are giving the BT, ideally we should give packed cell volume. We should not give the complete blood. Complete blood contain fluid also, plasma also. Okay, if plasma will cause the overload, we should give the, but in periphery, in blood bank, suppose packed cell volume is not available and the whole blood is available. And you have to give the whole blood only. So you keep on giving the whole blood to save the patient. But the patient will have volume overload. 5 liters se uska 10 liter ho jayega. Heart will fail. No. So along with that, give the diuretic. So all the extra fluid will be excreted simultaneously if it is required. Okay. So these are the uses. So I hope each and every use I explained you in detail. You can understand the meaning why diuretics are useful in these conditions. Now learn a mnemonic and move ahead. So the mnemonic is hemat. You have hematology na? In pathology, the same hemat. H-E-A-M-T-T. Okay. H stand for hypertension. E stand for edema. Make A as heart. Make A as heart. It is congestive heart failure. M as malignancy, hypercalcemia of malignancy, and 2 T are there. One is transfusion, blood transfusion, and one is intoxication. So what are the uses? Say hemat, H-E-A-M-T-T. Instead of A, I will make a heart, a beautiful heart. So I will say the uses as hypertension, edema, congestive heart failure, malignancy, hypercalcemia of malignancy, transfusion, intoxication. People, I tried. At least I tried from the depth of my heart. Whether you got it or you didn't got it, I don't know. But I tried. I have explained you each and every point, how they are the uses of the diuretic. Okay. Now coming on the adverse effect. Adverse effect also very easy. You can understand very easily. Total 11 adverse effect. How many 11? How many adverse effect are there? Total 11 of them are there. They can see. Now I will explain you all. So you have to see this diagram. Everyone on the screen. You understood the mechanism of action? I'm sorry. You understood the mechanism of action? I will revise it one. So what this furosemide is doing? Furosemide is inhibiting this pump, this transporter. What this transporter does? Normally, if we don't use furosemide, if we don't use the loop diuretic, it transports 5 ion in the blood from urine to blood. Which 5 ion? It is a transporter for the sodium, chloride, potassium, magnesium, and calcium. And wherever there is a sodium, there is water also. So the last one is the water. Sodium and water follows. So all these 6 things you can say, they are transported from the urine to the blood via this transporter. All 5 or 6 things. If you include water also, there are 6 things. If you inhibit this transporter with furosemide, so all the 6 things will reduce in the blood. They will not come in the blood. They will not come in the blood. They will be high in the urine. All 6 things. All. Which 6 things? You know the names. So sodium, potassium, chloride is not important. You can leave. Sodium, potassium, magnesium, calcium, and water. All these are high in the urine because this transporter is inhibited. They are not coming in the blood. So they are low in the blood. Which 5 things? Sodium, potassium, chloride is not important. You can leave. Sodium, potassium, calcium, magnesium, and wherever there is a sodium, there is water. So there is hypo. Can I say furosemide causes hyponatremia? Yes. So shall I say furosemide causes hypokalemia? Yes. Hypocalcemia? Yes. Hypokalemia, hypocalcemia, hypomagnesemia, and dehydration, and hyponatremia. These are the 5 adverse effects. Out of the 11, 5 are done. 5 you can learn like hypokalemia, hypomagnesemia, hypocalcemia, hyponatremia, and dehydration. Hypo. So if you can understand from this, it's good. If you can't understand, make a mnemonic. 5 things are hypo. PM and HC. What 5 things are hypo? Potassium, magnesium, sodium, water. Water is H2O and calcium. P, M, N, H, C. The 5 things are hypo: potassium, magnesium, sodium, calcium, and water. So these 5 are hypo. They reduce in the blood. So these are the 5 side effects of hypo. These are the 5 side effects of hypo. Now this is a human body. Everyone see, this is a human body. In the human body, do you know we have pancreas as a gland? Of course, retroperitoneally we have a gland. The name of the gland is pancreas. This is pancreas in human body. Pancreas have beta cells in that. These are the beta cells, and these beta cells secrete insulin in the blood whenever we eat. You know that, Hannah, the endocrinology. Now, for the secretion of insulin, the beta cell require potassium. If the blood have the potassium will go inside. It will do the knock on the beta cell, and beta cell will secrete the insulin in the blood. This is a normal process in me, you, everyone. Whenever we eat food, this happens. So if I eat the food, so the potassium will go. Potassium will stimulate the beta cell and the insulin. Now what happens? This person have taken a tablet of furosemide or Lasix, okay, the loop diuretics. So what is the potassium level of this person? You say, ma'am, you told us the potassium is less. PMNHC, hypo-PMNHC, hypo-P yani hypopotassium. So potassium is less potassium is there, so it will not stimulate the beta cell. So insulin will be less. Since insulin will be less, the person will be hyperglycemia. The glucose level will be high. This is the reason why the person is hyperglycemia. When the glucose is high, the lipid is also high. It will disturb the lipid profile also. You know, diabetics have impaired lipid profile. So hyperglycemia and hyperlipidemia. So two hyper, you have to learn two hyperglycemia and hyperlipidemia. I told you the reason. People, मैं सिर्फ learn करने को नहीं कह रही. I'm telling you the mechanism of each and everything of to you. No one will teach you like such a in depth. I'm trying. So what is the reason for hyperglycemia? What is the reason for hyperlipidemia? You can relate these two things with the hypokalemia. Since there is hypokalemia, insulin is not there. No insulin. So that's why hyperglycemia. That's why hyperlipidemia. Say yes. And I guess you already know hyperuricemia. I told you. So as I told you, the furosemide. Suppose I'm having edema or hypertension or congestive heart failure. I'm having any of the indication for furosemide or Lasix. Okay, you know the 5 indications. I'm having hemat. I'm having one of the hemat. I'm having indication. And for this, any of this, you are giving me map, take Lasix. I'm having hypertension or edema or congestive heart failure or hypercalcemia of malignancy or intoxication or BT. I'm having any of the indication. For that, you are giving me furosemide. You are giving me loop diuretics. You are a good doctor and you are giving me. I'm taking it. So either you will give me orally or you will give me injectable. Whether you are giving me orally, it will absorb in my blood. Whether you are giving me injectable, it is going in my blood. So this is furosemide. Here you can see. It is in my blood. It is in my blood, but it cannot act from the blood because it want to inhibit the transporter which is present on the luminal side. It cannot inhibit this transporter yahin se aisa. It don't have a magic stick ki wahin se kar diya. It has to go that side. So how it will go that side? How the furosemide will go? It will use a transporter. It will use a transporter, the taxi, the auto rickshaw, the vehicle, whatever you say. The transporter, the mediator, that will transport it. That will transport the furosemide from this side to this side. This is a transporter. So from where this transporter is coming? This transporter is a natural transporter for uric acid. Normally it transports uric acid from here to there, and uric acid is excreted in the urine. But whenever both are present, they will do competition. Uric acid will say, no, it's my transporter, furosemide. Why you are using it? Furosemide say, I am stronger one. Now I am present in the body. I will use it and you will not use it. So furosemide have more affinity. Furosemide will push the uric acid and use this transporter and go on that side. So uric acid concentration in the blood will be high. Normally uric acid is excreted in the urine. Okay, but now uric acid concentration is high. That's why hyperuricemia or cloud. So one of them is hyperuricemia also. So hyper is 3 things. Hyperglu, glycemia, lipidemia, and uricemia. So 5 things are hypo and 3 things are hyper. 5 things are hypo. We are talking about blood. Please mind it. So hypo. 5 things are hypo and 3 things are hyper. 3 things are hyper. Can you tell me the mnemonic? What are the 5 things are hypo? Say PMNHC. PMNHC. And hyper is GLU. GLU. Can you see the full form? So in the blood, potassium, magnesium, sodium, calcium, and water. Water is H2O. Their concentration will fall in the blood. And glucose, lipid, and uric acid, their concentration is high. So hyperglu. You can learn like that. If you understood, it's good. If you don't understood, learn it. Learn the mnemonic. Okay. So please learn the 8. 5 plus 3 total 8 side effects. How many of you got it? Anyone have any confusion? By the way, the concentration of all these will reverse in urine. They are less in blood. The one which are less in blood, they are more in urine. The one which are high in blood, they are less in urine. Anna, so please understand your question very well, whether they are asking the concentration in blood or they are asking the concentration in urine. If they are asking the concentration in blood, this is the mnemonic hypo and hyper. But if they are asking in urine, everything will reverse. The hypo will become hyper and the hyper will become hypo. I hope you are understanding. I hope the things are tricky, but I'm trying the best. Okay, G. So 5 plus 3 are there, 8, but remaining 3 are, apart from this, 3 more side effects are there. Number 1, it is teratogenic. All of them, they are unsafe in pregnancy. Not teratogenic, but they can cause hypotension in the baby also, in the fetus also. So never give diuretic, any of the loop diuretic in any pregnant lady. So pregnancy, they are unsafe. Number 1. Okay. Number 2, hypersensitivity, allergy can occur with anything, so allergies se bhi hogi. Number 2. And number 3, ototoxicity, they are ototoxic, permanent hearing loss can occur at high doses if used constantly. So ototoxicity can be there. Number 3, ototoxicity. So number 3 is ototoxicity. So please say the total 11 this thing, total 11 side effects, total 11 adverse effects or side effects of loop diuretics. Loop diuretics, we are done. Can you tell me what are the hyper? 5 of them are hyper. 1 2 3 4 5. 3 of them, I'm sorry 3 of them are hyper, 5 of them are hypo. Okay, and 3 are additional. Total 11 are there. Hyper is GLU, GLU. Hyperglycemia, hyperlipidemia, hyperuric acid. Hypo is PMNHC, PMNHC, potassium, magnesium, sodium, water, and calcium. And apart from that, they have the allergy, hypersensitivity, unsafe in pregnancy, and most important, ototoxic. So total 11 side effects. I am done. Basically, I am done with this chapter. Read the question, tell me the answer. You want to see the chart first? Let me show you the chart first. This is the loop diuretic, we are done. The loop diuretics, we are done. Are you people there? What I told you, we will study all the drugs in the tubulated form. It will take time. I know I'm having less time, but I cannot compromise with the quality. That's not my pattern. Okay. So whatever I will teach you up to the mark. Okay, although it will take time, I agree, but it will fit in your memory permanently. Anyways, so this is the master chart for the diuretics. We are trying to make the first diuretic we have completed is the loop diuretics. How many drugs in this category? Only 3 drugs. What are the 3 drugs in this category? Furosemide, bumetanide, and torsemide. These are the 3 drugs in this category. What is the mechanism of action? Imagine the diagram. They act on loop of Henle, the ascending limb of loop of Henle. You know the mnemonic cold P, don't forget that. And what does they do? In this cell, on one side there is lumen, on one side there is blood. So on the luminal surface there is a transporter. The name of the transporter is sodium potassium 2 chloride. They inhibit this transporter. What are the uses? We are having 6 uses and we are having 11 side effects. The uses is HEMAT, HEAMTT, hypertension, edema, A को heart बना दो, congestive heart failure, malignancy, hypercalcemia of malignancy. The 2 T are toxication, intoxication, and transfusion. And adverse effect, 5 of them is hypo, PMNHC, है ना, potassium, magnesium, sodium, calcium, and water. And 3 of them are hyperglycemia, lipidemia, uricemia, and 3 of them are extra, the ototoxicity, pregnancy, and allergy. So total 11. In this way, you can learn them in less than 1 minute. You can revise it. Make master charts. The key of pharmacology is master charts. Make master charts of all drugs, all units, all chapters. Imagine you are having master charts. You have understood all the chapters and make the master charts like this. Now for explaining this, I require 30 minutes, but revising, we require 1 minute. This is a way you should go. Give me a thumbs up. You want me to continue? So shall I tell you the next one? Thiazide. Before that, we will solve some question on this one. Read the question and tell me the answer. Loop diuretics such as furosemide act by. Loop diuretic, furosemide act by. What is the mechanism of action of loop diuretic? Huh? Is it decreasing tubular reabsorption of the sodium and increased GFR? Is it decreasing potassium, proton secretion with resultant increase in sodium and potassium excretion? Or is it inhibiting sodium potassium chloride transporter in the thick ascending limb of loop of Henle? Or is it inhibiting sodium potassium exchange in the collecting duct? Yes, the correct answer is C. So number 1, they are acting in thick ascending limb of loop of Henle and they inhibit this transporter on the luminal surface. Okay, yes, absolutely right. The next question, which of the following is not an adverse effect of furosemide? Not an adverse effect of furosemide. Which of the following is not an adverse effect of furosemide? Can you tell me? So first you tell me the adverse effect, then we will fit. So there are 5 hypo and 3 hyper. Hypo is PMNHC, hyper is GLU. You get many questions on this and students are really confused. So first of all, hyperuricemia, I guess yes, hyperuricemia is a side effect. Hyperglycemia, yes, hyperglycemia is also a side effect. Hyperlipidemia, yes, it's also a side effect. But hypermagnesemia, no, it's hypomagnesemia, not hyper. So incorrect among them is D. This is how you can apply. Okay, so incorrect among them is D. Things are very simple. The only thing you must understand it. Okay, the next question. Furosemide causes all except. Again, it's based on side effect. They are asking except. So again, hypo, hyper. Hypo are 5 things. P, M, N, H, C. And hyper are 3 things. G, L, U. Now see, the first they are saying hyperglycemia. It's there. Hypomagnesemia. It's there. Hypocalcemia, kalemia, it's also there. P is kalemia. Acidosis, no, not at all. Acidosis will be a side effect of carbonic anhydrase inhibitor, that is acetylcholine. Here metabolic acidosis will not occur. So incorrect among them is D again. No, not B. Some students are getting confused. Why you are getting confused? I hope the correct answer is D and you are getting it. Okay. So can we come on the next one? Let's start the next one. Thiazides. One more I will teach you. I will not teach you this one, this one, this one. Because you got the pattern, you can do it by yourself. Okay. Because if I teach you all, I can teach you only one unit, not others. I have to teach you all the units. Huh? So thiazides also we will take. Most of the question from furosemide or thiazide only. But I cannot say that these will not have any questions in your exam. I cannot say that. Maximum questions are from these two. That's why I'm covering these two, the prototype drugs. So let's come on the next one. The next one is the thiazide. The next drug is the thiazide in the same categories we will say. Same headings. First tell me the drugs, then mechanism of action, then uses, then adverse effect. The same thing. So drugs. How many drugs we have? Thiazides. We have these drugs in the thiazides. How many drugs we have in the thiazides? In the thiazides, we divide the drugs in 2 categories. The benzothiazines and the thiazide-like. Okay, benzothiazines have hydrochlorothiazide, hydroflumethiazide, benzthiazide. Looking at the suffix thiazide, thiazide, you can recognize them. They are thiazide. But these are the drugs, they don't have suffix as thiazide, so you have to mug them. You have to learn them. So it is chlorthalidone, metazolone, zipamide, indipamide, clopamide. So please better concentrate on these because they have the thiazide as a suffix. Anyways, you will recognize them. If you don't learn, it's okay. But here they don't have a suffix as thiazide, so you have to learn them. So these all are thiazide or thiazide-like drugs. What is the mechanism of action? First, you tell me the site of action. Apply the mnemonic cold P. So this is C, this is O, this is L, this is T, and this is P. I'm teaching you thiazide. Where is T? T is thiazide. Where it is acting? On DCT. It acts on DCT. Where was L was acting? L. Just now I taught you L, loop diuretic. It was acting on ascending limb of loop of Henle. But thiazide is acting on DCT. Thiazide is acting on DCT. So please learn it is acting on DCT, not on loop of Henle. The site changes now. The loop diuretic, you can see it was acting here, but thiazide is acting here. Please see the site is different. The organ is same. It's nephron. It's nephron only in the kidney, but the site is different. Say yes if you got it. So can you see one cell of the DCT I have drawn? In the DCT, the entire DCT is lined by the cells, but I have drawn only one cell. Can you see the cell in the DCT? Appreciate this cell. On one side of the cell, there is lumen. You all can see this is the lumen. On one side, there is lumen, and on other side of this cell is having the blood capillary. Okay, so let me zoom this portion on the next page. On the next page, you can see this is a cell. This is a cell this time of DCT. Okay, on one side there is lumen containing the urine. On other side there is blood capillary containing the blood. I hope you got it. So please understand we are talking at this portion. So imagine a human body. Imagine the kidneys, the 2 kidneys. Imagine 1 million nephron in each kidney. So inside each nephron, the 1 million nephron, the 1 million DCT. Inside the DCT, imagine the cells of the DCT, and one side of the cell of the DCT is lumen and one side is the blood. Now what happens normally? First you understand that normally on the luminal side there is a transporter. The name of the transporter is sodium chloride, not sodium potassium chloride, which was there in loop diuretic. Please understand, in the loop diuretic the name of the transporter was sodium potassium 2 chloride. Here only sodium chloride transporter is there. Sodium potassium 2 chloride transporter is not there. Okay, only only sodium chloride transporter is there. So it is present in me, you, everyone, all healthy normal individuals. So sodium and chloride from the urine, they come inside the cell, and after coming inside the cell, sodium will also go in the blood, chloride will also go in the blood. So sodium and chloride will move in the blood. Sodium and chloride. This happens normally. Currently, it's happening in me, you, everyone. In our kidney, in our nephron, in our DCT. This is happening constantly in all of us. So whatever sodium and chloride present in our urine, they are reabsorbed in the blood via this transporter. Imagine I'm having edema or somewhere something, and one of the doctor prescribed me thiazide. I'm taking a tablet of thiazide. Either I'm taking a tablet or I'm getting an injection. Whatever form it is going in my blood. So tablet also absorb, go in blood. Injection also going in the blood. So this is the thiazide, one of the thiazide. You know, a list of thiazide, one of the thiazide present in the blood, because tablet also go in the blood after absorbing the oral form. Injection also goes in the blood. Now from the blood, it has to inhibit this transporter. From this side, it cannot inhibit. So it has to travel that side. It has to travel that side. So this is the thiazide. It will use a transporter. Again, the same transporter, the uric acid transporter. ये भी uric acid को धक्का मारेगा. So this is a natural transporter of uric acid. Normally uric acid sit on it and travel from here to there and get excreted out. But whenever uric acid and thiazide both are present, है ना, there is a competition and thiazide is having more affinity than uric acid. It will push the uric acid, sit on the transporter, use the transporter of uric acid and go on that side and reach that side. So that's why whenever someone is taking thiazide for long, the uric acid concentration in the blood will be high, causing hyperuricemia. You got my point. Hyperuricemia is a side effect of this also. Like loop diuretics, the same story. Now thiazide reached this side. After reaching this side, what it will do? It will inhibit this transporter. This transporter is inhibited. So sodium and chloride, they will not go in blood. They will remain in the lumen also. The lumen only, urine only. They will remain in the urine. So sodium will be in the urine. Chloride in the urine. Wherever there is a sodium, there is water. Water is also in the urine. So sodium, chloride and water are in the urine. So is it a diuretic? What's the definition of diuretic? Diuretic is a drug that causes excretion of sodium and water. Chloride का भी excretion हो रहा है, but that is a side effect. We want excretion only of sodium and water. So this is a diuretic. This is the mechanism of action. I tried. Got it. So what is the mechanism of action? Thiazide diuretics, first of all, from the blood, they come on the luminal side. From the blood, they come on the luminal side using a transporter, using an organic transporter of the uric acid. Number one. After coming this side, they inhibit this transporter. They inhibit sodium chloride symporter, which is present on the luminal surface of the DCT. Okay, that's why these ions are not absorbed. Neither sodium nor chloride will be absorbed in the blood. They will remain in the urine only. They will remain in the lumen also. So sodium chloride along with the water, they will remain in the fluid only, and that causes diuresis. That is the mechanism of action. Now what are the uses? Let me tell you the uses here. So uses here the same, है HEA is same. What are the uses in loop diuretics? HEA MTT, hemat. Here HEA is same. HEA, the first three are same only, है but apart from these three, we use RD. Two are different. Please understand, the first three are same. So here also H is hypertension, E is edema, and A को heart बना देंगे, congestive heart failure. The first three are same actually. So you can, hypertension में you can use thiazide also, loop also, but thiazide are better one. If thiazide is not responding, then go for loop. So thiazide is the first choice for hypertension. They are the first choice for, among the diuretics, they are the first choice for hypertension. Hypertension, we can use loop also if they are resistant to the thiazide. Number two, edema. Number two, edema. Okay, for pulmonary edema, loop diuretics were good. But for hepatic or cardiac edema, thiazides are good. Okay, cardiac edema or hepatic edema, thiazides are good. So for edema, you can use. And for congestive heart failure, we can use both. For congestive heart failure, first three uses are same, but the next two are different. Now, I want to explain you something here. What should I explain you here? How should I explain you? Now, it's difficult. Please understand. You tell me the side effects of loop diuretic. I told you, na? And then I will tell you the side effect of thiazide. I will compare the both. Okay, you tell me here what was the hypo and what was the hyper. Then I will tell you what is the hypo here, what is the hyper here. We will understand. We will not mug up. We will understand. Here 5 things were hypo, if you remember. PMNHC. Yes or no? And 3 things were hyper. The hyper was glue. Okay, if you remember. Only one change in thiazide. What is that? Calcium, instead of hypo, it's hyper. That's it. The remaining are same. So here hypo is only 4. PMNH. PMHN. Or NH, whatever. PMNH. Not C. C will jump that side. So here instead of glue, it's gluco. So it's hyperglycemia, hyperlipidemia, hyperuricemia, hypercalcemia. Okay, and hypo mein hypopotassium, that is hypokalemia, hypomagnesemia, hypo sodium, natremia and dehydration. H2 is water. So calcium is opposite. Calcium is opposite. Please mind my words. Please mind my words. Loop diuretic decreases calcium concentration in the blood, but thiazide increase calcium concentration in the blood. Please mug it. If you understood, it's good. If you didn't understood, mug it. The reason I will explain you. The reason. You know the reason in the loop diuretics. In the loop diuretics, let me show you that diagram. Let me go back and show you that diagram. I want to show you. In this diagram, I told you this transporter transport 5 things. What are the 5 things? The 5 ions. What are the 5 ions? The transporter is transporting sodium, chloride, potassium, calcium, magnesium. Now, since this transporter is inhibited by furosemide or loop diuretic, all 5 will fall in the blood. All 5 will remain in the urine only. They all 5 will be more in the urine, and they all 5 will fall in the blood. 1, 2, 3, 4, 5, including calcium. You can see calcium is one of them. Calcium is one of them. Okay, that's the reason why calcium is less in case of loop diuretic. Now let's come on the Lasix. Are you people there? Keep responding here. Now let's come on the thiazides. What is happening in the thiazide? In the thiazide, this transporter is transporting only sodium and chloride, not potassium, not calcium. So here, if this transporter is inhibited, calcium is not related here. Calcium is not related here. But you have to understand here, we are talking about DCT. DCT. Okay. In the DCT, we are having the receptors of parathormone here. The parathormone receptors are present. You know, PTH, the parathormone, PTH receptors are present. These receptors are stimulated by thiazide. We are giving thiazide drug here. So thiazide is acting on the DCT. DCT activate the parathormone receptor. What does the parathormone do? Parathormone causes more and more absorption of calcium. So calcium absorption will increase, and in the blood there is high concentration of calcium. So reason is different here. So here calcium concentration is high. You are getting my point? You are getting my point. That's why we are reversing the use. Here 3 uses are same. The 4th use is hypercalcemia with calcium stone. What is calcium stone? Have you heard about a disease? इसको हिंदी में कहते हैं पतरी हो गई. पतरी, you know, I mean stones are there in the kidney. Kidney stones, renal stones are there. You may have heard this problem. With many people have this problem. Kidney stones are there. Why they have kidney stones? They have high calcium concentration in their urine, and this calcium get accumulated and form the stone. So if you want to prevent them further, now it is a recurrent. There is a, suppose I am having a kidney stone and you have operated me. One of the stone is removed, but it is a recurrence. Again I can have. It is have a tendency to recurrence. Why? Because my urine can have more calcium, and it will precipitate and form the stone again and again. If I want in future, I don't have recurrence, I have to reduce the calcium in my urine. So I can use this drug. What is this drug? Thiazide. What does thiazide do? Thiazide absorb the calcium from the urine to the blood. In the blood, there will be high calcium, but in the urine will be low. And that's why we can use it for the renal stone. At least I am trying. So renal stone occurs whenever there is high calcium in urine. There is no problem with high calcium in blood, but there is high calcium in urine that will precipitate and form the stone. So if you want to prevent the stone formation, you have to reduce the calcium concentration in the urine. You can do so with the thiazide. Thiazide reduce calcium in the urine and increase it in the blood because of absorption with the parathormone. And last is diabetes insipidus. So the mnemonic is HEARD. What is HEARD? HEARD. The uses of thiazide. H for hypertension, E for edema, A for heart, congestive heart failure, R for renal stone, D for diabetes insipidus. The first 3 are same. Now coming on side effects. The side effects are again, you can see 11. The same 11. Hypo, hyper, I told you, they are same instead of calcium. The calcium is reverse. So 4 hypo, 4 hyper. And 3 are different. One is pregnancy, the same. You cannot give thiazides also in pregnancy. One is allergy, and one is they cause renal toxicity. They were causing ototoxicity, they cause renal toxicity. We are done. Okay, so same thing. So you can see hypo and hyper for the loop diuretics and the thiazide. See the loop diuretics, see the thiazide. See hypo, hyper. Here hypo were 5 things, PM and HC. And hyper was glue. Here C coming from here to here. So hypo is only PM and H. You can compare. And hyper is gluc. C is coming from here to here. So here 5 and 3, here 4 and 4. But total is 8. You are getting my point. We are done with 2 diuretics till now. People, please reply, respond, react, do something. Are you excited? You are getting it in an easy way. Yes, no, respond. Chalo, we will revise it. We are done with two diuretics. The two main diuretics now will come on the next unit. Okay, so loop diuretics and thiazides, the most important two diuretics are done. In the loop diuretics, the drugs are furosemide, bumetanide, and torsemide. In the thiazides, there are many drugs which ends at the suffix thiazide. Along with that, we have clopamide, indapamide, zipamide. Okay, you have to learn these drugs. Now, what is the site of action? This act on loop of Henle, this act on DCT. Okay, you know the mnemonic COLT-P, COLTP. Okay, this inhibit a transporter known as sodium potassium 2 chloride transporter present on the loop of Henle. And this inhibit a transporter known as sodium chloride transporter present on the DCT. You know the mechanism of action is very easy. Now coming on the uses. Okay, in the uses you can compare. Here the mnemonic is hemat, here the mnemonic is hurled. Okay, see, H is same in both of them. Hypertension. Both of them can be used in hypertension, but better to use thiazide. Thiazide is first choice, followed by diuretic. If not responding, followed by going with the loop diuretic. First is thiazide. So if any hypertension, I will teach you today only hypertensive drugs, antihypertensive. There are 4 first line drugs in hypertension, ABCD. You know ABCD. A for ACE inhibitors or ARTs. B for beta blockers, C for calcium channel blockers, and D for diuretics. In the diuretics, we have 2 choices, loop diuretics and thiazide. So first choice is thiazide, followed by loop. First choice is thiazide. That's what I'm saying. So in hypertension, we can use both, but first choice is thiazide. The second is edema. For edema, we can use both, but first choice is loop. For hypertension, the first choice is thiazide. But for edema, the first choice is the loop because that is strong, no? That is high ceiling. Okay. So that is E for edema. A is congestive heart failure. Make a heart over here, make a heart over here. Both of them. But the remaining are different. Here M for malignancy, hypercalcemia of malignancy. Here T for transfusion, blood transfusion, and one more T is for toxication. Here R is renal stone and D for diabetes insipidus. I want to highlight one use. So here hypercalcemia of malignancy and here renal stone. These uses are based on the calcium. Okay, please understand. Loop diuretic increase calcium. Loop diuretic reduce calcium level in the blood. And thiazide increase calcium level in the blood. Based on this use is there. Here we want to reduce calcium level in the blood to treat hypercalcemia of malignancy. And here we want to increase calcium level in the blood so that in the urine it can be reduced so that we are treating the renal stone. Please understand. I'm trying from the depth of my heart, people. No one will explain you with such a clarity. Say yes. Say yes. Okay, soon I will conduct the revision, the complete revision of all these subjects you people are saying. Okay, soon we will conduct so. So can we go ahead? So please understood the uses. And now coming on the adverse effect, hyper, you already know. Huh? So rather than reading it passively, that's not my way. I will write it. Loop, thiazide. Uses, say the uses. Say ma'am, HEAMTT. Here HEARD. I told you the full form. Now the adverse effect. Here we have hypo, hyper. So what is hypo here? Hypo is PMNHC. Hyper is glue. Here only C will come from here to here. So here hypo will PMNH and here the hyper is gluc. I tried. At least I tried. Apart from that, 3 more side effects are there. Hana, in the pregnancy, both are avoided. Hypersensitivity allergy, both can cause. Okay. The third, this one is ototoxic and this one is renal toxic. Learn that. So 11 side effect. Okay. 11 adverse effect. Learn the uses. We are done. The mechanism of action you already know. This is the way you should learn pharmacology. Crystal clear. Okay, can we go ahead? We are done. Okay, read the question, tell me the answer. We'll move on the next chapter quickly. Thiazide diuretics causes all except. They are asking except. What does thiazide do not cause? Thiazide diuretic causes all except. What does thiazide do not causes? Read. So it's hyperglycemia, yes or no? Increased calcium excretion, yes or no? Useful in congestive heart failure or decreased uric acid excretion. So please understand before you say your answer. So what are the uses? The uses is HEARD, HEARD. And what are the side effects? It's hyper PMNH and hypogluc. मैंने उल्टा बोल दिया. I said it reverse. So this is hypo and this one is hyper. Now read the options. Read the options one by one. It causes hyperglycemia. Yes, of course it causes hyperglycemia. You are right. It useful in congestive heart failure. Yes, A is heart failure. So it is useful in congestive heart failure. It decreases uric acid concentration. Since it decreases uric acid concentration, it increases the amount of uric acid. Concentration of uric acid in the blood. Yes, it decreases uric acid concentration. But what about the calcium? It increases calcium excretion? No, it decreases calcium excretion. That's why it increases the concentration of calcium in the blood. So please understand the things are reversed in the blood and the urine, people. So correct answer among them is B. Okay, I hope you are getting it. D is not the answer. It decreases uric acid excretion. That's why it increases the uric acid in the blood. So the things are reversed. Whatever you say hyper in the blood, in the urine hyper will reverse. Please use that concept. Okay, the next question. Which one of the following is not an adverse effect of thiazide? Not adverse effect of thiazide. You see the adverse effect. What is hypo? What is hyper? Hypo is PMNH. Hyper is gluco. PMNH. I'm sorry. Hyper is glu. Now apply it. Quickly apply it. You can do so. Hypoglycemia? No, my God, it's hyperglycemia. Hypoglycemia don't occur. But hyponatremia? Yes, hyponatremia occur. Hypokalemia? Yes, hypokalemia occur. Hyperuricemia? Yes, hyperuricemia occur. So first one is wrong. So based on that, you can answer your questions very easily. Okay, can we go ahead? Can I start the next unit? How was the first unit? How do you find it? Was it easy? Was it moderate? Was it difficult? How was the unit renal system? Renal pharmacology. Huh? Was it easy? Was it moderate? Or was it difficult? How you find it? Or was it interesting? Whatever it is. The most important, it should be interesting. Easy, moderate, difficult doesn't matter. It should be interesting and conceptual. Okay, yes. You got it? Everyone? So diuretics are done. The remaining 3 diuretics, you can do it of your own. You got the concept how to do so. Coming on the next unit, cardiovascular system. We are done with the renal system. Let's come on the cardiovascular system. Okay, let's start cardiovascular system. In the cardiovascular system, I want to teach you 3 systems here. The drugs which are acting on renin-angiotensinogen system known as RAS. Renin-angiotensin system, RAS. The drugs for the heart failure and drugs for the hypertension, antihypertensive drugs. One by one, we will take the 3 chapters. Are you interested? It is more interesting as compared to renal. It is very interesting. The CVS pharmacology. I love it. Okay, chalo. So let's start the drugs acting on renin-angiotensinogen system. Before understanding the drugs acting on renin-angiotensinogen system, student may ask, ma'am, what is renin-angiotensinogen system? I don't know. Can you explain me? Hota kya hai? Mere mein hai kya? Yes, we all have the system. So we have a system. We have a proteins in our blood, a set of proteins and enzymes in our blood. The family is known as RAS family. What is the full form of RAS? Renin-angiotensinogen system. God has given this inbuilt system in all of us. In all of us. God is great. And God has given the system. You will say, ma'am, what is the meaning of that and what is the use? Why God has given the system? What does the system consist of? And when does it get activated? I will answer everything. Let's start with RAS. So before understanding the drugs acting on the RAS, you must understand RAS. अगर RAS ही नहीं समझा तो drugs acting on RAS पढ़ के क्या कर लोगे, है ना? So point is that if you want to understand the drugs acting on the RAS, first understand RAS, then you will understand the drugs acting on that. So let me tell you what is renin-angiotensinogen system, RAS. You can see here I'm teaching you renin-angiotensinogen system. Okay, we all have blood pressure. Okay, what is the normal blood pressure? Systolic and diastolic. So we all have blood pressure. If we measure the systolic diastolic blood pressure, normally it's 120 by 80 mm of mercury. Normally, plus minus 10, 20 is okay. Okay, but normal blood pressure is this. Suppose there is fall in blood pressure in any of the individuals suddenly due to any reason. For example, I'm having vomiting. For example, I'm having severe diarrhea. For example, unfortunately, I got an accident and my blood loss is there. For example, unfortunately, I'm having a surgery. In the surgery, there is severe blood loss. Or any of the reason we are having the fluid loss. I'm having some trauma. I'm having something, surgery, accident, vomiting, diarrhea, fluid loss is there. We all have 5 liters of fluid. If due to any reason fluid loss is there or due to posture change, anything, if there is sudden fall in blood pressure, the person can die. If I'm having sudden fall in blood pressure, I can go in shock and I can die. If I'm having this blood pressure, all the organs are getting the blood. If the blood pressure will fall, suppose someone is having blood pressure 60 by 40. Oh my God, 60 by 30. It's severe hypotension. The person is in shock. The organs are not getting the blood. There is multiple organ failure. The brain will die, the person will die. God do not want that. God is great. So if someone is having less blood pressure, suppose I'm having vomiting, diarrhea, blood loss or anything, if my blood pressure fall, this system will come in role. Renin-angiotensin system. At that point, it will come in role. Currently, my blood pressure is normal. I don't think it is fall right now. So whenever we have fall in blood pressure, we feel dizzy. We have vertigo, we feel dizzy, lightheadedness. These are the symptoms. So currently, I am not feeling so. My blood pressure is normal. So this system is not activated right now. It is there in me as a backup God has given, but it is not activated right now. It will come in action only when the blood pressure will fall. Whenever the blood pressure is fall, my blood, your blood, all of our blood contain a protein. The name of the protein is angiotensinogen. It is present in me right now. Who synthesizes this protein? The liver. Liver synthesizes this protein from the alpha-2 globulin. So liver have already synthesized and put in the blood. So my blood vessel contain this protein. Okay, but it remains like inactive form only right now because my blood pressure is normal. But imagine if my blood pressure falls suddenly now due to any reason. So immediately, blood is going everywhere. From head to toe, we have hundreds of organs. Blood is going everywhere. Whenever the heart is pumping, the blood is coming in the aorta, and via aorta, the blood is distributed everywhere from head to toe. Kidney is a sensor. God has given a sensor. The kidney is the sensor. In the kidney, there is a cell known as JJ cell. Juxtaglomerular apparatus. Juxtaglomerular cells are there. They are the sensor. You know what is a sensor? Sensor is a cell which senses the blood pressure immediately. So as soon as the blood pressure falls due to any reason, vomiting, diarrhea, accident, surgery, due to any reason, if the blood pressure falls, JJ cells in the kidney, they sense it. Blood is going everywhere. Blood is going in kidney also. So if the less pressure wala blood, the blood with a less pressure going everywhere, it is going in the kidney also. JJ cells will immediately sense it. As soon as the JJ cells sense there is a less blood pressure, oh my God, JJ cells secrete renin enzyme in the blood. Normally, I don't have renin enzyme in my blood right now. But if I have fallen blood pressure, my JJ cell will secrete it in the blood. So renin is an enzyme which is secreted by the juxtaglomerular cells of the kidney. Okay, whenever there is a fall in blood pressure, not normally. What does this renin will do? Renin will act on this protein which is already present in my blood. I'm having this protein in my blood, but I don't have renin enzyme in my blood. So if I have fallen blood pressure, then renin enzyme will come and degrade this protein. This protein is degraded into angiotensin 1. This angiotensin 1. Now the lungs. Now come bari aati hai lung ki. Lungs secrete another protein, another enzyme. The name of the enzyme is angiotensin converting enzyme, ACE. What is the full form of ACE? Angiotensin converting enzyme, because it is converting angiotensin 1 to 2. नाम में उसका मतलब है. It is converting angiotensin 1 to 2. That's why angiotensin converting enzyme. It is converting angiotensin from 1 to 2. So this enzyme is secreted by lungs. Later on, first kidney secrete renin, then lung secrete ACE, and ACE convert angiotensin 1 to 2. Bas, ye angiotensin 2 act on 6 organ. I will tell you 6 organ in human body which is having angiotensin receptors on that. 80 receptors. Angiotensin receptors are present in 6 organ, and via acting on 6 organ, they normalize the PP. So God has given the backup. So imagine my blood pressure. So first you see, this is liver. You can see, say yes. Liver is synthesizing a protein. The name of the protein is angiotensinogen, which is present in my blood right now, in your blood right now, in all healthy individual blood right now. They all have this protein, but it's inactive protein. It don't do anything. Whenever someone is having fall in BP due to any reason, any reason. Suppose in the morning I suddenly get up. I was in supine position and I got erect. I was standing position. Suddenly, you should take a करवट लेके उठना चाहिए. एकदम से if you are changing the posture, the blood is going in the legs and sometimes we feel dizzy as soon as we get up very quickly. So we shouldn't do so. The right way of getting up in the morning, you may be knowing that, I guess. Okay. So suppose if I'm getting suddenly, or I'm having bleeding, or due to any reason, my blood pressure falls. So my sensor, my kidney have a sensor. God has given JJ cells in my kidney. They will sense the blood pressure is low and they will secrete the renin in the blood. From the kidney, the renin is coming. The JJ cells of the kidney, the renin is coming. Renin is an enzyme. Angiotensinogen is a protein. This enzyme act on this protein and convert it into angiotensin 1. Now this angiotensin 1 will go in the lung and stimulate it. The lungs will secrete another enzyme. The name of the enzyme is ACE. What is the full form of ACE? Angiotensin converting enzyme. It converts angiotensin 1 to angiotensin 2. This angiotensin 2 will act on the 6th organ. I will tell you the name of the 6th organ, and they increase the blood pressure and make it normal. Currently, suppose my blood pressure is 100 by 60. So again, this angiotensin 2 act on the 6th organ And because of which my blood pressure again rise to 120 by 80 and I will feel normal. And this all happens within a fraction of time. पढ़ाने के लिए time ज़्यादा लग रहा है लेकिन होने के लिए time नहीं लगता. It happens in fraction of time. We one don't think about blood pressure. I feel dizzy and in the next moment I feel better. है ना? So in a fraction of time this all things are happening. You know, God is great. We are just understanding the things, and the one who have created all, Hannah, you can't thank enough. Okay, it's very complicated, we think, but imagine someone have created all these mechanisms in our body. I sometimes really get surprised, the God who have created all these things, the mysteries, and we are trying to understand that. Okay, sometimes I feel कि कैसे बनाया है ये सब इतना complicated जो हमको समझ में ही नहीं आता, पर बन के इनबिल्ट है हमारे अंदर and it is constantly functioning. We are trying. ये तो हमारे अंदर अभी भी काम कर रहा है. Okay. Anyways, चलो. So this family is known as RAS family. So in a RAS family, we are having 3 proteins and 2 enzymes. Total 5 members are there. What are the three proteins? Angiotensinogen. It get converted to angiotensin 1. It get converted to angiotensin 2. The 3 proteins. And for this conversion, 2 enzymes are required. What are the 2 enzymes required here? The first enzyme is renin and the second enzyme is the ACE. Renin is secreted by kidney and ACE is secreted by lung. Total 3 protein, 2 enzyme, the family of 5. The family of 5 is RAS family, and this family is present in our blood, inbuilt. It is given by the God to prevent us from hypertension. God is great. God has given the backup so that we don't die with shock. We don't have hypertension. Okay. And we don't die with hypertension. So this system is present in all of us. You say, yes, ma'am, it's a very good thing. And God, we are thankful to God for the system. Now, first thing, before coming on the disease, I would like to tell you what are the 6 organs on which this angiotensin 2 is acting and how it is increasing the blood pressure. It is acting on 6 organs. 6 human organs have receptor for angiotensin 2. The name of the receptor is known as AT receptor. What is the name of the receptor? AT receptor. So AT receptor is present on 6 organ. Let me tell you which 6 organ. Number 1, blood vessel. Can you see? This is a blood vessel. This is a blood vessel. So AT, can you see the dot? This dot is AT. I have drawn the AT receptor. This is AT receptor. So this angiotensin 2 is coming and acting on the AT receptor and causing vasoconstriction. When the vasoconstriction is there, blood pressure will rise. Hana, number 1. It is causing vasoconstriction in the blood vessels. Number 1. Number 2, heart. Can you see this? This is AT receptor. So this angiotensin 2 is coming and binding on the AT receptor of the heart. It increases 3 things in the heart. The rate of the heart, the force, the contractility. Rate, force, contractility. All the things will increase in the heart. Number 2. Okay. Number 3, it is present on the kidney. Can you see? This is kidney, AT receptor. So this angiotensin 2 coming and binding on the kidney and causes sodium water retention. If my body have more sodium means more water. My body will have more water. More water, my blood pressure will rise. I want to increase the blood pressure now because my blood pressure is fault. I want to increase it and normalize it. Sodium water retention will be there in the kidney because of this. Again, my blood pressure will rise. Okay, the 4th, above kidney, we have a gland, adrenal gland. So on adrenal gland also we have a AT receptor. So this angiotensin 2 come and bind on the adrenal gland and increase the synthesis, increase the release of the aldosterone. You know aldosterone, what does aldosterone do? Aldosterone will again cause sodium water retention. It will further cause a sodium water retention and again it will exaggerate the BP. It will increase the BP. The 5th organ is the brain. In the brain, it acts on the pituitary and it increases the synthesis of ADH. It increases the synthesis of ADH hormone from the posterior pituitary. So because of the ADH, there is more thirst. We feel thirsty. We drink water, again our blood pressure will rise. And finally, it acts on the nerves, the sympathetic nerves. The sympathetic nerves. This is having the receptor on the sympathetic nerves. Sympathetic receptors, you know, sympathetic activity increases the blood pressure. So based on these 6 organs, the blood pressure rises again. Say, how many of you got it? How many of you got it? So what happens whenever blood pressure falls? Imagine my blood pressure falls suddenly due to any reason. My normal blood pressure is 120 by 80, but due to any reason it falls. Maybe due to trauma, accident, surgery, vomiting, diarrhea, dehydration. No, my blood pressure is falling due to any reason. Okay, now what will happen? The God has given a backup. In my blood, angiotensinogen is present. Okay, so it is present. It is synthesized by the liver. So as soon as the blood pressure will fall, it is sensed by the kidney. Kidney will secrete renin, the JJ cells. Renin convert angiotensinogen to angiotensin 1. And another enzyme will come from the lung, that is ACE. ACE will convert angiotensin 1 to angiotensin 2. Angiotensin 2 receptors are AT receptors. These AT receptors are present on 6 organs. What are the 6 organs? Number 1, blood vessels. Number 2, heart. Number 3, kidney. Number 3, above the kidney, we have adrenal gland. Number 5, brain, and from the brain the nerves are coming. Okay, based on which the blood vessels have vasoconstriction, The heart have increased force, rate, and contractility. Kidney causes sodium water retention. Aldosterone secrete adrenal gland is secrete aldosterone, which again causes sodium water retention. Brain may say ADH, which is causing thirst, and the nerves causing sympathetic activity, because of which the blood pressure rises again and it become 120/80. So it is a backup. Okay, it is a backup. You say it's okay, ma'am, but why you are teaching us this backup right now? So what is the role of RAS inhibitors? We are teaching us the drugs acting on the RAS. Now, so what is the role? Now, if you understood normal, how many of you understood normal? Give me a thumbs up. Give me a thumbs up. How many of you understood normal? If you understood normal, then tell me. Now I will tell you the drugs. Listen, listen, listen. You know, after 50 years of age, most of the people become hypertensive. I guess everyone knows. What is hypertension? Rise in BP. Okay, most of the. How many of you parents are hypertensive? Of how many of you, maximum of you, the grandparents are hypertensive? Okay, or any elder in your family, in your relatives, in your known, in your neighbors who are more than 50 years, they are hypertensive. They are on anti-hypertensive treatment. They are hypertensive. है ना? बहुत लोग बोलेंगे कि बीपी की बीमारी है, बीपी की गोली लेते हैं. They say in Hindi like this, है ना? Most of the people. Have you ever thought why it is very common? After 50 years of age, what happens in human body so that person become hypertensive? We will also become more than 50 years. Most of us will also become hypertensive. You, most of us. Why? What happens in our body? Huh? What is the most common cause of hypertension after 50 years? What is the most common cause of hypertension? I'm asking for primary hypertension. What is the most common cause? 90% hypertension. You know what is the reason? You know what is the reason? Overactivation of RAS. Overactivation of RAS with old age. Overactivation. The RAS is a family. The RAS is a family having 3 protein and 2 enzymes. God has given this family, total 5 members family, 3 protein and 2 enzyme as a backup. Whenever the blood pressure fall, listen, whenever the blood pressure is less, okay, please understand, the RAS get activated. It's a good thing. It will save me. The RAS will get activated and it will make my blood pressure normal. Okay, by activating and acting on the 6th organ. Acting on the 6th organ, it will normalize my blood pressure. I'm thankful to God for that. Okay, but imagine if I'm having normal blood pressure and my RAS get activated. What happens? My blood pressure is normal. I don't need RAS. Currently, my blood pressure is 120/80. But what happens is my RAS get activated. I do not want it right now, but it become defective. Imagine. The backup is defective. It become overactivated and it is acting on the same 6th organ. So if I'm having the, ab usko nahi pata, BP normal, it increases BP acting on the 6th organ. So I will become hypertensive. I will become hypertensive. So that happens in old age. I hope you are getting it. If the BP is less, then RAS is getting activated. It's a good thing. It will make the BP normalize. But if the BP is already normalized and RAS get activated because of overactivation, the person become hypertensive. So most of the time, the reason for hypertension is not atherosclerosis, Osama. Atherosclerosis is the most common cause of cardiovascular events. You are right, but not for hypertension. The primary hypertension, the most common reason is overactivation of RAS. The RAS get overactivated in old age, especially after 50 years or 60 years, it become overactivated, it become defective. God has given a backup, but backup become pagal ho jata hai backup. The backup become defective. Even at normal blood pressure, it become oversensitive. It become activated. So person become hypertensive. Now imagine this person is coming to me for treatment. Patient more than 50 years, no other comorbidity, only hypertension. The most common cause is overactivation of RAS. So if you want to treat this hypertension, inhibit RAS. So we will read the drugs that will inhibit RAS. People respond. No one will teach you such a conceptual pharmacology, but I'm trying. So I appreciate the efforts. Got it? So this is the thing. This is the thing. Got it? So overactivation of RAS. We will treat the overactivation. So 80% of the hypertension is due to overactivation of RAS. So if you want to treat the hypertension in old age, you have to inhibit the RAS. So how we can inhibit the RAS? What are the levels? We want to inhibit the RAS. There are 3 levels. Please imagine. See here, everyone on the screen. Number 1, you can give a drug that inhibit the renin inhibitors so that angiotensinogen do not convert into angiotensin 1. Angiotensin 1 ही नहीं बनेगा, ना रहेगा बांस, ना बजेगी बांसुरी. Angiotensin 1 नहीं है तो 2 कहाँ से आएगा? 2 नहीं आएगा तो 6 organ पे जाएगा कौन और BP कौन बढ़ाएगा? You are getting my point. So we are giving renin inhibitors so that angiotensinogen do not convert into angiotensin 1. If there is no angiotensin 1, there is no angiotensin 2. No angiotensin 2. No one will act on the 6th organ and no one will rise the BP. BP will fall again and person become normal. So first level of inhibition is renin inhibitor. Second, give ACE inhibitor. If you don't give renin inhibitor, it's okay. Don't give renin inhibitor. Give ACE inhibitor. So if you give the ACE inhibitor drug, angiotensin 1 will form. It will form, but it will not convert into angiotensin 2. Main is angiotensin 2. Angiotensin 2 is not formed. Angiotensin 2 is not formed. No one will act on the sixth organ and no one will rise the BP. BP will fall again and person become normal, normotensive. You got my point? That is the second level. If you don't want to inhibit this also, either you inhibit renin or you inhibit ACE. Don't do both. Either you inhibit renin or you inhibit ACE. If you don't want to inhibit both, I'm not inhibiting renin also. I'm not inhibiting ACE also. It's okay. It's okay. Do the third thing. What is the third thing? Third thing, block the receptors. Can you see the receptors here? Can you see the receptors? Yes. These are the receptors on the sixth organ. Give a blocker. Give some blocker that is blocking the receptors on the sixth organ. The receptors are blocked. Angiotensin receptor blocker, ART. See the full form of ART? Angiotensin receptor blocker. It is a blocker of angiotensin 2 receptor. Now, angiotensin 2 is formed. There is no one who is holding. So, we are not inhibiting the renin. We are not inhibiting the ACE. So, angiotensinogen getting converted into angiotensin 1. Angiotensin 1 is getting converted. Angiotensin 2. Angiotensin 2 is formed. लेकिन जाके act कहाँ करेगा? जहाँ act करेगा, we हमने block कर दिया. So, we have blocked the receptor of angiotensin 2. So, the third drug is angiotensin receptor blocker. So, we can do 3-level blockage. We can block the RAS at 3 levels. Number 1, we can block renin. Number 2, we can block ACE, renin inhibitor, ACE inhibitor, or angiotensin receptor blocker. What are the 3 drugs, people? They are in front of you. Say, ma'am, renin inhibitor, ACE inhibitor, or angiotensin receptor blocker. Say yes if you all got it. So this is the 3 type of drugs we have in the system. All of them are used to treat hypertension. These are antihypertensive drugs. So we have renin inhibitor, we have ACE inhibitor, and we have ARB, angiotensin receptor blocker, AT receptor blocker, angiotensin receptor blocker. People respond, got it or didn't got it. So this is the mechanism. One more thing I forgot to tell you before starting the details. I would like to tell you one more thing here. Let me explain you one more thing here. You have to see this again. I forgot to tell you one thing because, okay, so chalo. What I'm teaching you the RAS family. In the RAS family, what we have? God has given a protein in our blood. The name of the protein is angiotensinogen. It is currently present in me, you, all of us. In the blood, we have this protein. Who synthesized this protein? The liver synthesized this protein. It is present in our blood, but it is inactive. Suppose if I have fall in blood pressure due to any reason, so my kidney, the JJ cells of my kidney will sense it and the kidney will secrete an enzyme in the blood that will act on this protein. So angiotensinogen will degrade it into angiotensin 1 by renin. Now this angiotensin 1 will go in the lung and activate the lung. Lung will secrete another enzyme. The name of that enzyme is ACE. So, and ACE will convert the angiotensin 1 to angiotensin 2. Angiotensin 2 will act on the sixth organ and increase the BP. You know how. So finally, how many enzymes we have? We have 2 enzymes. What are the 2 enzymes we have? We have 3 proteins and 2 enzymes. The 3 proteins is angiotensinogen, angiotensin 1 and angiotensin 2. The 3 proteins are there. And we are having 2 enzymes. What are the 2 enzymes? Renin, which is secreted by kidney, and ACE, which is secreted by the lung. Okay, now please highlight ACE. Renin will come role only whenever we are in hypotension. Currently, I don't have renin in my blood. It is secreted by JJ cells of kidney only if I have hypertension. But in the lungs, ACE is present. ACE is present in the lungs normally also. Currently, my lungs have ACE. My lungs, not my blood. My blood don't have ACE because I'm not hypotensive right now. Okay, but my lungs have ACE. All of our lungs have the ACE. Okay, what is the normal function of ACE in the lung? Why God has given ACE in the lung? ACE is present normally in the lung. It will come in the blood only if hypertension is hypotension is there. Blood pressure will fall. But in the lung, it's normally present. So normally, it converts bradykinin and substance P in our lung to inactive products. In our lung, constantly bradykinin and substance P are formed because of various metabolism. So मेरे lung में substance P बनता रहता है. मेरे lung में bradykinin भी बनता रहता है. So in my lung, bradykinin and substance P are formed in all of us. But thankfully, God has given ACE to us. So all of our lung have the ACE. And ACE convert bradykinin and substance P into inactive. Because if ACE is not there, bradykinin and substance P will not degrade and they will cause the cough. I don't have cough, thankfully, because my lungs have the ACE. Okay, now imagine, you imagine what I'm saying. So a hypertensive person is coming, more than 50 years, 60 years, an old hypertensive person is coming to me. The blood pressure is raised and the person wants me to treat it. Okay. So what 3 options? Renin inhibitor, ACE inhibitor, and angiotensin receptor blocker. Suppose I'm giving ACE inhibitor. So ACE inhibitor, what they will do? ACE inhibitor will inhibit the ACE. ACE inhibitor will inhibit the ACE. ACE will be inhibited. So we are thankful that if ACE is inhibited, one thing is good. One thing is good, that angiotensin 1 will not convert into angiotensin 2. Angiotensin 2 will not form and it will not act on the sixth organ and BP will fall again. Okay, so this is a good thing. But ACE inhibitor will inhibit the ACE in the lung also. That is a bad thing. That is a side effect of ACE inhibitor. So if the ACE inhibitor in the lung will be inhibited, if ACE in the lung is inhibited by the ACE inhibitor, bradycardia and substance P will not be degraded, and bradycardia and substance P will cause the cough. So most common side effect of ACE inhibitor is cough. You can correlate, and they cause the edema also. Edema and cough is the side effect of the ACE inhibitor. People respond, I'm trying. You got it or you didn't got it? Okay, so this is the complete theory. You can see, you can understand. Nobody is going to ask you this, but you have an understanding of this. Now you can understand the drugs very well. So can I teach you 3 drugs now? I will teach you 3 drugs. What are the 3 drugs? Renin inhibitor, ACE inhibitor, and angiotensin receptor blocker. So these are the 3 drugs in this chapter, the RAS family. The RAS. These are the 3 type of the drugs. So we are having renin inhibitor, we are having ACE inhibitor, and we are having angiotensin receptor blocker. Among them, the most commonly used is ACE inhibitor followed by angiotensin receptor blocker. Renin inhibitor, we don't use it normally. You learn the classification. Renin inhibitor may one drug, Alice Kiran. Here the suffix is Kiran. Alice Kiran. That is the suffix. Okay. ACE inhibitor may the suffix is Pril. The suffix is Pril. It captopril, enalapril, lisinopril, perindopril, ramipril, fosinopril, quinapril, and pterandopril. So suffix is pril. And angiotensin receptor blocker may suffix is sartan. The suffix is sartan, losartan, chandartan, valsartan, telmisartan, irbesartan, olmesartan. So all of them are sartan. Okay, got it? What antidote mechanism you are asking? Malik, can you please specify? Okay. Okay, can we go ahead? Yes. So please learn. So Kiran, you can say Renin. Renin may, you can learn. Kiran may, and may REN, and here these are the renin inhibitors. You can correlate like that also. Got it. Okay, can we go ahead now? Okay. So we will take 3 categories one by one. Again, the master charts. We will make this master chart. I will teach you all 3, like the diuretics also. We will make master charts here also. So first of all, I will teach you the ACE inhibitor. Then I will teach you the ARBs, and then I will teach you the renin inhibitors. In each of them, you have to tell me the drugs, the mechanism of action, the uses, the adverse effects, and contraindication if any. Let's start the first category, ACE inhibitor. Now you got the overview. Can we start? Give me a thumbs up, everyone. Give me a thumbs up. Why it get overactivated, Nikki? There is no reason for that. It's physiologically in old age, due to some degeneration, it can get overactivated. Not in everyone. The one in which it is overactivated are the persons who are hypertensive. But with lifestyle modification and something like physical activity, using less sodium in the salt, less salt in the diet, less sodium, like all these, it can be controlled. But if the lifestyle is not very healthy, it can get degenerated or it can get overactivated in old age. Got it, Nikki? Can we go ahead? Give me a thumbs up. Come on, people. Got it. Chalo. Let's start the first chapter, ACE inhibitor. Tell me the drugs. I told you all the drugs contain the suffix pril. All the drugs contain the suffix pril. You already know the drugs. Tell me the mechanism of action. You can understand. The mechanism of action, it's a drug which inhibits ACE. ACE inhibitors inhibiting ACE. So angiotensin 1 is formed, but angiotensin 1 do not convert into angiotensin 2. So if angiotensin 2 is not formed, it will not act on the 6th organ. If it is not acting on the 6th organ, blood pressure will fall and blood pressure become normalized. So ACE inhibitor, ACE is an enzyme which convert angiotensin 1 to 2. ACE inhibitor inhibit ACE. So angiotensin 2 is not formed. 1 is formed, but 2 is not formed. 2 is not formed, so it will not act on the blood vessel. It will not cause vasoconstriction. It will not act on any of the organ, and blood pressure will rise, blood pressure will fall again, and blood pressure will normalize. What are the uses? Main use is hypertension, but apart from that, other uses are also there. So I'm having a mnemonic. The mnemonic is home care makes patient definitely strong. Home care makes patient definitely strong. Home care makes patient definitely strong. Okay, learn it. H stands for hypertension. It is used in hypertension. You can understand. C for congestive heart failure, because it is causing vasodilatation, and it is decreasing the preload and afterload. M for MI. It can be used after MI so that the recurrence of the MI do not occur, that second attack do not occur. So it can be used prophylactic as MI after first attack. But if a person is having high cardiovascular risk, like the person is obese, physically inactive, diabetic, and high risk of MI in future, we can give prophylactic also. So prophylaxis of MI can also be there. MI after MI and as a prophylaxis of MI, P for prophylaxis, D for diabetes nephropathy we can give, and S for scleroderma crisis in which the person is having high hypertension, severe hypertension, hypertensive crisis. So these are the uses. So please learn. Home care makes patient definitely strong. H for hypertension, C for congestive heart failure. Okay, what is M? What is M? MI. P, prophylaxis of MI. D for diabetic nephropathy, and S for scleroderma crisis. So please learn the uses with the help of a mnemonic. The adverse effect is captopril itself. Captopril is a mnemonic for the adverse effect. So C stand for cough. A stand, you can see cough. Okay. A stand for angioneuritic edema. You know, the complete edema on the face, on the larynx, person can't breathe, it's an emergency, angioneuritic edema. And here I stand for itch. You can see captopril ka I stand for the itching. These three things are due to bradykinin and substance P. I told you we are inhibiting ACE. ACE. So one good thing will happen, one bad thing will happen. The good thing is that if you inhibit the ACE, angiotensin 1 do not convert into angiotensin 2. Angiotensin 2 will not form. And angiotensin 2 will not act on its receptor on the sixth organ. So BP will fall. BP will not rise, BP will fall, and person become normal, normotensive. That is a good thing. This is the ACE inhibition in the blood. But if you are giving an ACE inhibitor, the ACE will be inhibited in the lung also. In the lung, normally ACE convert bradykinin and substance P to an active product. Now this is inhibited. So bradykinin and substance P are not degraded. And bradykinin and substance P cause three things. The person have cough, the person have edema, angioneuritic edema, and the person have itch. So these three side effects are due to bradykinin. How many of you understand? How many of you understand? Okay, so this is cough. You can see this is cough, this is angioneuritic edema, and this is itch. These three are due to bradykinin and substance P. Okay, P for proteinuria, increased protein in the urine. P for proteinuria. T for two things. Number one, teratogenic. Don't give it in pregnancy. And number two, taste disturbance. Taste disturbance, okay, but main is teratogenic. Never give ACE inhibitor to any pregnant lady. It's teratogenic. O for others. Others may fatigue, headache. P for potassium increased. It increases the potassium. Potassium is increased in the blood. Hyperkalemia. And R for renal impairment. Because it is renal impairment, that's why there is proteinuria. You can understand. Renal impairment is causing proteinuria. And L is causing low BP. It will decrease the BP. Like with the first dose, BP can be suddenly low. Suppose I am hypertensive. I'm coming to you. Doctor, I'm feeling headache and all since last few days. My vision is blurred. You are measuring my BP. Oh my God, ma'am, your blood pressure is raised. You are hypertensive. So you are measuring it repeatedly on 2-3 days and it is constantly raised. And I'm more than 60 years, for example. You will say, ma'am, your RAS is overactivated. You have to start on antihypertensive. The best antihypertensive I can start you is ACE inhibitor. And you have given one of the Pril. You have started me on telmisartan. Most commonly, people take telmisartan. You have given me the drug, but you have started with a full dose. So today I have taken it. My blood pressure will fall extra. I am hypertensive. My blood pressure currently is 160 by 100. Okay, I want to make it 120 by 80. But if you give first dose suddenly, first dose ke baad, hypertension can suddenly fall. It can be 100 by 80, like that. So don't give first dose suddenly. So increase it gradually. So first you give half dose, then gradually you increase it. Otherwise the person can go hypotension. कुछ ज़्यादा ही इफेक्ट हो जाएगा, है ना? कुछ ज़्यादा ही इफेक्ट हो जाएगा. ब्लड प्रेशर कम तो करना है, लेकिन कम करके नॉर्मल करना है. कुछ ज़्यादा कम नहीं कर देना है. मैं हाइपरटेंसिव हूँ तो मेरे को ब्लड प्रेशर कम करके नॉर्मल बनाना है. मेरे को कम करके शॉक में नहीं जाना है ना? So low BP can be the side effect if full dose is given. First dose pe especially the hypertension can occur. So these are the side effects. So can you enumerate the uses and side effect of ACE inhibitor? I'm done with ACE inhibitors. Can you tell me uses? What are the uses? Can you tell me the adverse effect? What are the adverse effect? Uses is home care make patient definitely strong. Can you say the full form? Hypertension, congestive heart failure, MI, prophylaxis of MI, diabetic nephropathy, and scleroderma crisis. Okay, adverse effect, the mnemonic is captopril. C-A-P-T, capto, P-R-I-L, captopril. इसमें से three of them are due to bradykinin. That is cough, that is angioneuritic edema, and that is itch. These three are due to bradykinin and substance P. P for proteinuria. Proteinuria is due to renal impairment. O for others. Okay, one more P. P is for potassium increase. ये बहुत important है. Potassium will increase. T for teratogenic and taste disturbance, and L for low BP. So you have to learn it. Okay, and the contraindication. There are 4 contraindications. The contraindication is PARC. Never give it in pregnant lady. Never. A for allergy. Allergy तो किसी से भी हो सकती है. Hypersensitivity. All drugs can have allergy. R for renal artery stenosis. Never give in a single kidney or renal artery stenosis. Never. And K for potassium, hyperkalemia, because it increases potassium. The person already have hyperkalemia and you are giving ACE inhibitor, it will further increase the potassium. The patient can go in arrhythmia. No, if the person already have hyperkalemia, never give ACE inhibitor. So this is how you go. Got it? So you tell me we are done with ACE inhibitor. I will show you the chart directly. This is the chart. We are done with the first drug. Master charts. I call them master charts. They are really master charts. Make them of complete pharmacology, not only of few chapters. Here, I'm having a rapid revision. I wish if I could have a conceptual course of pharmacology, I can teach you. So I can teach you pharmacology for hours and hours, and I can teach you all the master tables here only. But since it is a rapid revision, so I will give you an overview. The rest of the things you have to revise by yourself. So you have to make these master charts like this, and for all the drugs, for all the chapters of complete pharmacology, so that the big thick pharmacology book you can compact it in just 30-40 pages. So before going to your exam, revise the 30-40 pages. All the drugs are in your hand. You have just revised it. This is a way to read the pharmacology. Okay, anyways, so ACE inhibitors. ACE inhibitors, we are done. You tell me the drugs. Say, ma'am, all the drugs ending with pril. Very easy, है ना? Mechanism of action, obviously नाम में ही है. They inhibit the enzyme ACE. Since they inhibit the enzyme ACE, angiotensin 1 is not converted to angiotensin 2. Angiotensin 2 is not formed. 1 is formed, but 2 is not formed. Since 2 is not formed, it is not acting on the 6th organ. It is not acting on the 6th organ. Blood pressure will fall and blood pressure become normalized. What are the uses? Home care makes patient definitely strong. I assume you know the full form. What are the side effects? Captopril. I assume you know the full form. And what is the contraindication? PARC. That is pregnancy, allergy, renal artery stenosis, and hyperkalemia. Please learn. And I assume you know the full form. You want me to say the full form again? Please learn the full form of all mnemonic. Learning mnemonic is a separate thing. But first you understand the meaning of each of them and then make a mnemonic. It will be easy for you. Now if I say why it is used in hypertension, why it is used in congestive heart failure, why it is used in, you should be able to answer each and everything so that you have an understanding behind that. Okay, yes, definitely I will share the PDF after the class. Okay, so we are done with this. Coming on the ARBs, the next is ARB. First you enumerate the drugs, then the mechanism of action, uses, side effect, contraindication. Quick. So ARBs, what are ARBs? Angiotensin receptor blocker. So all the ARBs end in sartan, losartan, chandesartan, valsartan, telmisartan, irbesartan, olmesartan, all of them are sartan. Angiotensin receptor blocker, ARBs. Angiotensin receptor blocker. So what we are doing here, what we were doing in ACE inhibitor, we are inhibiting the enzyme ACE so that angiotensin 1 do not convert into angiotensin 2. No, here we are not inhibiting this. We are not inhibiting ACE. Let angiotensin 2 form. We are not inhibiting renin. We are not inhibiting ACE. So angiotensin 1 converted into angiotensin 1. Angiotensin 1 converted into angiotensin 2. Let it be formed. Let it be formed. But where does it bind? It binds with its receptor. Where are the receptors? 80 receptors, 81 receptors present on the 6th organ. So we are blocking the receptors on the 6th organ. So let's block the receptor. So now even if angiotensin 2 is present in the blood, where it will bind? Its receptors are blocked. Since its receptors are blocked, it cannot bind here and it cannot show its action. It cannot show its action. It will not increase the BP. BP will fall and BP will become normalized. I hope you're getting the story. I'm telling you big stories. Yes. So ARBs bind with 81 receptors on 6 organs. They block the 81 receptors on the 6th organ. Now angiotensin 2 present in the blood, but it cannot bind with its receptor. Since it cannot bind with the target organ, the 6th organ, no action. No action means the BP will fall and BP will become normalized. So you will see, ma'am, how means which one is better? The thing is same now. Whether you are inhibiting the ACE, तो angiotensin 2 banega ही नहीं. Please understand. है ना? If we are using ACE inhibitor, so angiotensin 2 will not form. And in ARB, angiotensin 2 is formed, but it is not acting on its receptor. So which one is better? ACE inhibitor or ARB? Which one is better? To inhibit the ACE, is it better? Or to inhibit the receptor, to block the receptor? Which one is better? The mechanism is more or less same. A little bit one step difference. But which one is better? I'm asking you which one is better. So ARBs are better. Can you answer why ARBs are better than ACE inhibitors? Because whenever we were inhibiting ACE, one thing was good, that angiotensin 2 is not formed and these 6 organs, angiotensin 2, if it is not formed, it is not acting. One thing is good. But we are inhibiting the ACE in the lungs also, and bradykinin and substance P are not degraded. So patient have cough, patient have angioneuritic edema, and patient have itch. These were the side effects of ACE inhibitor. These side effects will not occur in ARB now. In ARB, you are not inhibiting ACE. Let it be. You are not inhibiting ACE in ARB. Hana? So ACE is functional in the lungs as well as in the blood. In the blood, let angiotensin 2 form. बन के क्या कर लेगा? बनने दो, मत डरो, बनने दो. Let it be formed. Let angiotensin 2 form. judega kahan? Where it will bind? The place where it will bind, you block that. That is angiotensin receptor blocker. So here we don't have the side effects of bradykinin. We don't have side effects. We don't have cough, we don't have angioedema, and we don't have itch. Remaining side effects are same. But these three side effects are not there in ARB as compared to ACE inhibitor. I tried, at least I tried. So I'm satisfied. Got it? So how ARBs are different from ACE inhibitors? I told you that. ARBs do not interfere with the degradation of bradykinin and substance P. So that's why they do not cough. They do not cause cough, rashes, dysgeusis, and itch, and all these things are not there. Uses are same. Home care makes patient definitely strong. Uses are same. The same uses are there. Adverse effect may you remove these three adverse effect. So remaining are hypotension, hyperkalemia, and teratogenic. So these adverse effects are same. So you can see we are done with the two categories. We are done with these two categories. So compare. We are done with this chapter also. Please compare. So you can see here the suffix is pril. All the drugs ending with pril. Here the suffix is sartan. All the drugs ending with sartan. Here the mechanism of action, it inhibit ACE enzyme, so that angiotensin 1 do not convert into angiotensin 2. Angiotensin 2 is not formed. Here angiotensin 2 is formed, but it cannot bind with its receptor. It is blocking the receptor of angiotensin 2. The uses are same in both of them. Home care makes patient definitely strong, where H stand for hypertension, C stand for congestive heart failure, M for MI, P for prophylaxis of MI and prophylaxis of MI, diabetic nephropathy, and scleroderma crisis. Uses are same, but side effect may. Here we have captopril, but here we don't have the cough, we don't have itch, and we don't have angioneuritic edema. The remaining are almost these only. The remaining are, so hypotension, hyperkalemia, and teratogenic. They are same. They are same. If you remove these three, the remaining will be there. The contraindication is PARC, you can say, or take care. No contraindication here. So we are done. Okay. Can we go ahead? Huh? Can we go ahead? So that is the thing. So we are done. These drugs are not very important, so we are skipping it. So coming on the next chapter, heart failure drugs. You want me to teach you the heart failure drugs also? The digoxin is the main drug here. Digitalis, digoxin. Can we start? Heart failure drugs. So CVS will also be done. So let's start the next chapter. We are done with the drugs acting on renin-angiotensin system, and now we are starting the heart failure drugs. So let's start heart failure drugs. You can see this is a human heart. Okay, this is a human heart, you all can see here. Now when the heart is pumping from the left ventricle, the blood is coming to the aorta, the pure blood, the oxygenated blood, and it is distributed in all the organs. When the right ventricle is pumping, the blood, the impure blood, the deoxygenated blood coming in the pulmonary artery and going in the lungs for the purification. So both the ventricle pumping is important. Imagine if any of the ventricle or both the ventricle are not pumping properly. If the left ventricle is not pumping properly or the right ventricle is not pumping properly. If the left ventricle is not pumping properly, what will happen? The blood will not go in aorta and the blood will go backward because it is not going ahead. So all the organs are receiving less blood in the left ventricular failure, and the blood is going backward. Blood is going backward from left ventricle to left auricle. From left auricle, it is going to pulmonary vein, and via pulmonary vein, it is accumulating in the lungs, causing pulmonary edema. So whenever a person have left ventricular failure, the person have two failure, forward failure, backward failure. In forward failure, the blood is not going forward and all organs are receiving less blood, so person is very lethargic. And the blood is going backward. So the blood is accumulating in the lungs. So person have pulmonary edema and person have dyspnea. So left ventricular failure, person have two complaints. Number one, lethargy. All the organs are receiving less blood, fatigue. And number one, breathlessness because of the pulmonary edema. That is left ventricular failure. Now coming on the right ventricular failure. Okay, and the right, I'm teaching you the pathology, people. You may be thinking, ma'am, this is a pharmacology session. Why you are teaching us pathology? Okay, but if you don't understand pathology, you can't understand the drugs acting on it. What we have to fix first, you have to understand the problem. If you understand the problem, then you will understand how to fix it. Hana, we will fix it with the drugs. We will fix it. First, understand the problem. If you don't understand problem, how you can understand its fixing? Hana, with the drugs, we are fixing the problem. Understand the problem first. What is the problem? Okay, so understanding pathology is very important for understanding pharmacology. You can't understand pharmacology without understanding pathology. Okay, treat किस चीज को करोगे? Problem ही नहीं पता तुमको, तो पहले problem तो पता कर लो, है ना? We are teaching you heart failure. First you understand what is heart failure, then I will teach you the drugs acting on the heart failure. So I told you two type of heart failure: left heart failure, right heart failure. Left heart failure, I told you in left heart failure, what are the complaints? Blood is not going ahead, so all the organs are receiving less blood. So person is very lethargic, fatigue, and blood is going backward. Since it is not going forward, the left ventricle is not pumping. Imagine the left ventricle is not pumping, so blood is not going forward, it is going backward. Via backward, it is accumulating in the lungs and causing dyspnea. breathlessness in the person. So that is left ventricular failure. What happens in right ventricular failure? Right ventricular failure. Again, the right ventricle is not pumping this time. This time the right ventricle is not pumping. If the right ventricle is not pumping, the blood is not going for the purification in the lung. And again, it is going backward. If it is going backward, it is going in SVC, IVC. It is going in SVC and IVC, and all the organs it is accumulating. All the organs internally in the body can have edema. So in left heart failure, the person have only pulmonary edema. And in right heart failure, person have edema of multiple organs in the body. Give me a thumbs up if you got it. Okay, this is heart failure, the two type of the heart failure. Okay, now, so if anyone's heart is failing, it's an emergency. Come on, heart is the vital organ. ठीक है, heart के बिना there is no life. So the most vital organ in the human body is the heart. If anyone heart is failing, it's an emergency, but God is great. God has given a backup. God has given backup for everything. Okay, imagine if someone heart is not pumping properly. Maybe the left ventricle, maybe the right ventricle. We are more of concerned here with the left ventricle. So if the heart is not pumping, the left ventricle is not pumping properly, it's an emergency. You know, in autonomic nervous system, we are having two systems, the sympathetic system and parasympathetic system. So during emergency, the sympathetic system get activated. You may be knowing that. Whenever there is an emergency, the sympathetic system get activated, not parasympathetic system. So here, when the heart is not pumping properly, the sympathetic system get activated automatically as a backup. So whenever the sympathetic system activated, three things will happen here as a compensation. One good, two bad. Total three things. Let me explain you. Then only I can teach you the drugs acting on the heart failure. Most of the students learn the drugs for the heart failure. They don't even know why we are using it, ma'am. They ask him, ma'am, why we are using vasodilators here, why we are using diuretics here, why we are using ACE inhibitors here. You don't understand the compensation, because first you understand the pathogenesis, the compensation, then it will be fun for you understanding the drugs. Please understand. So imagine someone heart is failing. See the two ventricles. So the ventricles are not pumping properly. Can you see? So left heart failure, the left ventricle is not pumping properly. Right heart failure, the right ventricle is not pumping properly. So person may be symptomatic or asymptomatic, but body will do the compensation. Hana? So it's an emergency. Heart is not pumping. Come on, sympathetic stimulation is there. Whenever sympathetic stimulation is there, three things will happen. Number one, on the heart, can you see the left ventricle? The wall of the left ventricle have beta 1. The wall of the left ventricle have beta 1 receptors. Hana? Beta 1 receptors are present. Everyone knows beta 1 receptors present in the wall of the left ventricle. Okay, they get activated. Hana? Because in sympathetic system, noradrenaline will be secreted. This noradrenaline will come combined with the beta 1 receptor, and it causes the contractility increase. Hana? Because heart is not pumping, we are increasing the cardiac output, we are increasing the contractility by stimulating the beta 1 receptor because of sympathetic activity. So imagine someone's heart is not pumping properly. Imagine a person whose heart is not pumping properly. So sympathetic stimulation is there. Because of sympathetic stimulation, noradrenaline will be released. Noradrenaline will come and bind with the beta 1 receptor present on the left ventricle wall. Noradrenaline will stimulate them, and beta 1 will cause the increased force of contraction, and cardiac output will increase temporarily. So temporarily patient is out of heart failure. Hana? The body have compensated. So thankfully God has given this system to us. Okay. What you are saying? Okay. Okay, got it. So here, it's like that. Number one, so you see, ma'am, it's a very good thing. Thankfully, God has given the beta 1 receptor in our left ventricle. So imagine the heart is not pumping. It's okay. The beta 1 receptor will take care of it. The sympathetic system will come and roll, and temporarily it will hold on and increases the cardiac output again. But when sympathetic system comes and roll, two bad things also happen along with one good. One good is beta 1 receptor on the heart. This is good. This is good. This is for compensation. But you know, beta 1 receptors are present on the heart. You can see they get activated. But two bad things will happen. One on the blood vessel and one on the kidney. In the kidney, when sympathetic system is activated, the noradrenaline is present in the blood. This noradrenaline go in the heart on the beta 1 receptor of the heart and increases the contractility. But this noradrenaline go in the blood vessels also. On the blood vessels, we have alpha receptors. It will bind with the alpha receptors and causes vasoconstriction. Vasoconstriction means it will increase the blood pressure, it will increase the resistance, it will increase the preload and afterload. Vasoconstriction of arteries and veins. Heart पहले देखो हिंदी में बोलती हूँ heart पहले ही काम नहीं कर रहा है ना. Imagine this heart is weak, it's not pumping properly. That's the problem ना, heart failure है ना. So what we want the aorta to be dilated or we want the aorta to be constricted? Heart is weak. We want the aorta to be dilated so that with minimal effort, with a little bit of contraction, the blood can go in the aorta. We want that. But imagine in that, sone pe suhaga, aorta become contracted. Heart is weak. Heart cannot pump, or aorta become contracted. So heart has to pump very harsh to push the blood in the aorta. No, that's not good. Whenever heart failure is there, we have to dilate. We have to decrease the resistance so that even with minimal efforts, the blood can move in the aorta. Please understand. Here, bad thing is happening, vasoconstriction. Vasoconstriction is not good. Heart was already weak and you are doing vasoconstriction. Heart cannot pump even in normal aorta. You are constricting the aorta. This is heart. This is normal aorta lumen. Heart even cannot pump the blood in that. Heart is weak. The muscles are weak. And you are even constricting the aorta. Heart even further will not be able to do that. So that is the thing. Give me a minute. My battery is low. I will not able to see your chats. I'm looking your comment in the mobile. No? Let me put it on the charger. I'm sorry. Done. Okay, so number one. So this was a bad thing. Okay. The second bad thing, the noradrenaline which is present in the blood, it will go in the kidney also. In the kidney, we have JJ receptor. It will stimulate the JJ receptor. Beta-1 receptors are present on the JJ receptor of the kidney. And it will increase the renin secretion. What does the renin will do? Just now I taught you. Renin will convert angiotensinogen to angiotensin 1. Angiotensin 1 convert into angiotensin 2. Angiotensin 2 will act on 6 organs. One of the organ is adrenal. It will cause the secretion of the aldosterone, and aldosterone will cause salt and water retention. पहले ही heart जितना we have 5 liter of blood, है ना? 5 liter of blood तो pump कर नहीं पा रहा. Heart is weak. Heart is unable to pump 5 liter of blood. उस पे सोने पे सुहागा, you are doing sodium water retention. So instead of 5 liter, person have 6 liter of blood. So these two things are bad. If the heart is failing, these two things are further failing the heart. Although it's a compensation, God is trying to do good for us, but instead of good, it is happening bad. One thing is good, but two things are bad. So imagine this is the heart. These are the 4 chambers of the heart. This is the left side of the heart. This is the right side of the heart, and it's a heart failure. The left side cannot pump. Imagine the left ventricle fails and it cannot pump. It cannot pump. So it's an emergency. As soon as the left ventricle cannot pump, the blood is not coming in the aorta, it's an emergency. Whenever it's an emergency, the sympathetic system will come in the room. Sympathetic system will cause the secretion of the noradrenaline. So it will do 3 things. What 3 things? Number 1, it will act on the heart itself. On the heart itself, these are the beta-1 receptors on the left ventricle. Okay, and it will cause the increased contractility of the heart, increased cardiac output. That's good. That's good. Only if this thing is good. The remaining 2 are bad. This noradrenaline will go in the blood vessel and causes vasoconstriction of the blood vessel, because alpha receptors are present on the blood vessel, and this will go on the kidney. It will go on the kidney. Okay, and here also beta-1 receptors are present. It will cause the renin secretion from the kidney. Renin will cause sodium water retention. Sodium and water retention. So out of the 3 things for compensation, the sympathetic system come in role because of the emergency. For emergency, the sympathetic system came in role. The noradrenaline came in role. But one thing it is doing good, but 2 things it is doing bad. The one thing it is good, it is temporarily increasing the cardiac output so that we are holding the heart. The person is not dying. Suppose my heart stop pumping, so I will not die suddenly. This noradrenaline will come in my blood and it will act on the beta-1 receptor on my heart and it will increase the contractility. So temporarily till I am shifted to the hospital, my heart is pumping at least. I will have the symptom and someone will shift me. If I am unconscious, someone will shift him. So temporarily it is increasing the cardiac output. It's a good thing. It's a good sign. For some time we are holding it for some time. But हार्ट इज ऑलरेडी फेलिंग एंड यू आर डूइंग वैसोकॉन्स्ट्रिक्शन. हार्ट उतना तो पंप कर नहीं पा रहा, उतने कॉन्स्ट्रिक्शन पे और कॉन्स्ट्रिक्ट कर दो एओर्टा, तो कैसे चलेगा? हार्ट 5 लीटर पानी तो पंप नहीं कर पा रहा, यू आर इंक्रीजिंग द वॉल्यूम. सो दीज 2 things are bad. These 2 things are which are occurring automatically. We are not doing it. So because of emergency system activation, sympathetic system activation, 1 thing is good, 2 are bad. You are getting it. So in heart failure treatment, we will inhibit this, and we will increase this. That is heart failure treatment. Now I will teach you heart failure treatment. You will have a better understanding. I hope you are getting it. I hope you are getting it. Say yes, say no, say something, respond. This is heart failure. Okay. So this is heart failure. Now, 1 thing is good, 2 thing is bad. So please understand what all drugs we can give. What all drugs? You understood the compensation, that what are the 2 things which are bad taking place. So 1 thing is good, I told you, but 2 things are bad. Please understand what are the 2 bad things. Number 1, because of sympathetic stimulation, the noradrenaline which is coming in blood, it is going to the blood vessel causing vasoconstriction. Vasoconstriction of the arteries as well as vasoconstriction of the vein. Where is artery? Where is vein? Vasoconstriction of the artery means vasoconstriction of the aorta. Aorta got constricted. है ना? So left ventricle cannot push the blood in that. It got constricted. It's already weak heart, and you're constricting the aorta. Not a good thing. And vasoconstriction of the vein. This is a vein, SVC, IVC. If veins are vasoconstricted, all the blood present in the vein is thrown in the heart. Heart is already weak, और तुम उसको और दे दो, है ना? वो उतना तो पंप नहीं कर पा रहा. तुमने जितना वेन में रखा था ब्लड वो भी उठा के इसको दे दिया, है ना? सो इट इज इंक्रीजिंग द प्रीलोड, इट इज इंक्रीजिंग द आफ्टरलोड. सो vasoconstriction of the artery increases the afterload, vasoconstriction of the vein increases the preload. Both are bad, both are not good for a failing heart which is failing, है ना? That is, this is increasing the afterload, this is increasing the preload, number one. So it is increasing the workload on a heart which is already failing, it is unable to do so, number one. Okay, this is a bad thing which is happening. Number two, this noradrenaline which is present in the blood during sympathetic activity, it is going to the kidney and causing the secretion of the renin. Renin is secreting aldosterone, and aldosterone is causing sodium water retention. More blood in my body. Instead of 5, I'm having 5.5 or 6 liter of the blood. Sodium water retention is there. So it is again increasing the preload. Again, it is causing the increased workload of the heart. So it will lead to cardiac remodeling or the hypertrophy of the left ventricle, which is irreversible, and it is the most common cause of mortality in CHF. So if you understood this, now let me tell you the drugs which are helpful. Please come back. Now, to inhibit this compensation, various steps I can block. What I can do? Number one, please understand, Anna, as a compensatory mechanism, one thing is good, two are bad. The good thing is increased cardiac contractility, and the bad thing is vasoconstriction and increased renin secretion. These are the two bad, Anna. So what drugs we can use here? Number one, to further increase contractility. Heart तो कर ही रहा है, हम बाहर से भी कर सकते हैं. We can use the inotropic drugs. Inotropic drugs are the drugs that act on beta 1 receptor that increases the cardiac contractility. Not on beta 1 exactly, but they increases the cardiac contractility further. Okay, via beta 1 receptor, already it's done by noradrenaline, but we will further stimulate it. So that is inotropic drugs, number one. Number two, we can give alpha blocker. We can give vasodilator, arteriodilator, venodilator. We can give beta blockers. We can give RAS inhibitors, that is ACE inhibitors and ARBs, to inhibit the secretion of the renin. We can give aldosterone antagonist, and because of sodium water retention, we can give the diuretics. I hope you are getting it. Anyone who didn't got it, these are the drugs we are using. You can't understand the drugs if you don't understand this compensatory mechanism. Anyone who want me to say the compensation again, or you want the mechanism of action of the drug, why we are using alpha blocker here, you understood? Why we are using beta blocker here, you understood? Why we are using diuretic here, you understood? Why we are using aldosterone antagonist here, you understood? Why we are using RAS inhibitors here or ACE inhibitors you are understood? Inotropic, everyone can understand. Heart is not pumping, you increase the contractility. That is inotropic. Inotropic is something that is increasing the force of contractility of the heart. We can understand, but remaining drugs, do you understood why we are using in the heart failure? If I directly show you the classification, these are the drugs we use in heart failure, you will not understand why diuretics, why ACE inhibitors, why ARB, what they have to do with the heart failure here. Now, but you have a better understanding. Now I can start the drug. Now I can start the drugs. Anyone have any confusion? You can understand the drugs only if you understand this compensatory mechanism. Hana? Imagine a heart. Let me draw it. I will say it once again. This is a heart. This is a failing heart. You can see this is the left ventricle. The left ventricle is not pumping. It's a failing heart. It's an emergency in human body. Imagine left ventricle is not pumping. The blood is not coming in the aorta and the body organs are not receiving the blood. It's an emergency. During emergency, the sympathetic system come in the role and noradrenaline will come in the blood. This will do three things. Number one, it go in the heart itself and it increases. It go in the heart itself and act on the beta 1 receptor of the heart and increases the contractility and cardiac output of the heart. This is good. But two things are bad. What are the two things that are bad? It will go on the blood vessel. Let me draw a blood vessel. And it will go on the kidney. The same noradrenaline. It will go on the kidney also. The same noradrenaline is going everywhere. The noradrenaline. Going in the heart, the beta 1 receptor. Going in the blood vessel, the alpha receptors are there. And in the kidney also beta 1 receptors are there. Okay. Here it is causing vasoconstriction. Vasoconstriction of the artery as well as vasoconstriction of the vein, which is not a good thing. Vasoconstriction of the artery is increasing the afterload. Vasoconstriction of the vein is increasing the preload. It is not a good thing. Okay. And in the kidney, the beta 1 receptors are present. It is causing the secretion of the renin. What does the renin will do? Renin will secrete the aldosterone. And what does the aldosterone will do? Aldosterone will cause the sodium water retention. Because of sodium water retention, as well as arterial constriction, as well as venoconstriction, there is increased workload on the heart. And a failing heart will further fail. Failing, पहले से ही failing था. हार्ट वॉज ऑलरेडी फेलिंग, इट विल फर्दर फेल. भाई फेलिंग पे और फेल कर दिया. पहले उतना काम तो हो नहीं रहा, तुमने और काम दे दिया उसको, है ना. 5 लीटर तो संभल नहीं रहा, तुमने और सोडियम वाटर रिटेंशन कर दिया, है ना. उतने पे तो वो प्रीलोड आफ्टर लोड पे संभाल नहीं पा रहा था, तुमने और प्रीलोड भी बढ़ा दिया आफ्टर लोड. सो इट इज नॉट. सो फेलिंग हार्ट विल फर्दर फॉल एंड पर्सन विल डाई. सो वी हैव टू block it at various levels, है ना. Now what all drugs we will use to improve it, what all drugs we will use to improve it. Number one, है ना, number one, we can increase the contractility. What is the problem? The left ventricle cannot contract now. Increase the contractility, increase. So give inotropic drugs, है ना. Already noradrenaline doing so, and noradrenaline acting on the beta 1 receptor and increase the contractility. We will further increase the contractility of the heart by providing inotropic drugs. Number one. Number two, we can give alpha blocker. Number three, we can give beta blocker. Okay. Number four, we can give arteriodilator. We can give venodilator, venodilator, alpha blocker. These are the drugs we are using. Here we can use beta blocker. Okay. We can use renin inhibitor. Okay. Renin inhibitors means RAS inhibitor, I mean. And ACE inhibitor, ARB. And we can give aldosterone antagonist. I told you in the diuretics, aldosterone antagonist was spironolactone. One of the potassium sparing diuretics, I told you. Aldosterone antagonist we give, that is and sodium water retention in the body, na, more fluid. Instead of 5 liter, there is 6 liter excreted. Give the diuretics. So these are all the drugs. Who are saying me to repeat? You got it? Krishna, you got it? Others, you got it? Nagma, I will try to cover. Ma'am, you will not cover in. I will try to cover if the time allows, but I don't think it today after CVS I will be able to continue because it is requiring. I will ask the team to give me one more session, and in that I will cover. I will try to cover. You want ANS also from my side? I do not want to compromise the quality. I can have a choice that I can take one drug of all the chapters and just like that. Just for the touching the chapter, I can do so, and I have said that I have covered the syllabus. That's not my pattern. If I'm teaching something, I should teach you with thorough knowledge, and that should be the justice with the subject as well as the student. After you are giving me time now, you are 1 hour, 2 hour, 3 hour, that's precious and that should be worth. Anna. So if you are giving the time after attending the session, you must feel that yes, it was worthy attending. So that is the main thing. It is not a wastage. Anyways, you got it? Can we go ahead? So this is the classification of the anti-heart failure drugs. You can see the classification is in front of you. We can use the inotropic drugs. We can use the RAS inhibitor. We can use the diuretics. We can use the vasodilator. We can use arteriodilator, venodilator, both dilator. We can use beta blocker. We can use aldosterone antagonist. Just now I taught you all these are the drugs. Now you can understand the mechanism of action of each of them. I mean, what is the use of each of the drug in heart failure treatment. But before teaching you this mechanism, if you don't aware about this compensatory mechanism, I told you heart failure में ये सारे ड्रग यूज करते हैं, तो तुम बोलोगे क्यों यूज करते हैं? ऐसा सोचना चाहिए तुम्हें कि मैम डायूरेटिक का क्या लेना क्या देना हार्ट फेलियर से. Why we are using arteriodilator, why you are using vasodilator, but now you can understand it well. Yes. Okay, so among them I will teach you the most important inotropic drug today. I will not teach you all, but I will teach you the inotropic drug. Which inotropic drug? Digitalis, digoxin, digitalis, whatever you say. So I will teach you the inotropic drugs. There are 3 inotropic drugs. One is cardiac glycoside, one is sympathomimetics, one is PDE3 inhibitors, phosphodiesterase 3 inhibitors. So among them, we will take the cardiac glycosides today. The remaining 2 you can do by your own. We will do the cardiac glycosides. Okay, cardiac glycosides. In the cardiac glycosides, again, the drugs, mechanism of action, uses, adverse effects, and contraindication. So cardiac glycosides, how many drugs we have? We have 2 drugs in the cardiac glycosides, digoxin, digitoxin. Digoxin, digitoxin together known as digitalis. So if I say digitalis, it includes both digoxin, digitoxin. Okay. Now what does it do? Where does it act? Tell me the mechanism of action. They are acting on the heart. Where on the heart? They are acting on the left ventricle cells. Can you see the left ventricle in this diagram? Have a look on the left ventricle. Can you see the left ventricle? In the left ventricle, can you see the yellow color cells I have drawn? I'm highlighting. Can you see the left ventricular cardiomyocytes? So this is the site of action where digoxin and digitoxin will act. So digoxin and digitoxin, both of them, I mean digitalis, acting on these yellow cells on the left ventricle. Can you see these cells? This is the, now on the next page, I will draw a yellow color cell, this one. So you must have an understanding ki cell kaun sa. You must have this yellow cell I have drawn. This is yellow color I have drawn. Can you see? This cell is this only. You can see this. It is a cell of the left ventricle. This is a cell of the left ventricle where I will show you the mechanism of action of digitalis and digoxin. Digoxin, digitoxin. I mean the mechanism of action of digitalis I will show you here. So it is acting on the left ventricle. It is acting on the cell of the left ventricle. Okay, left ventricular cardiomyocyte. This is a cell, you can see it here. Okay, now let me explain you. It's difficult, but I will try. Okay, what I'm teaching you, say ma'am, you are teaching us inotropic drug. What does the inotropic drug do? It increases the contractility of the heart. Contractility of the heart. It increases the contractility of the left ventricle. That is inotropic drug. How does it increases the contractility? What do you mean by contractility? I mean, see ma'am, there are two things which happens in the heart: systole, diastole. Systole followed by diastole followed by, so one cardiac cycle, one systole, one diastole. You know the cardiac cycle. So contractility means what? Contractility means systole or diastole? I guess you can understand. Contractility means systole. I want to increase the systole, the intensity of systole, the duration of the systole. I want to increase the systole. I do not want to increase the diastole. I want to increase the systole. So so digitalis increase the systole. But for understanding, you must understand how does normal systole and diastole takes place in the heart. If you don't understand how does normal systole and diastole takes place in the heart, you cannot understand the mechanism of action of the digitalis. You're getting my point? So first I will tell you how does in a normal heart, my heart, your heart, all normal individual heart, how does the systole and diastole takes place. So let me tell you systole and diastole story. Then I will tell you the mechanism of action of digitalis in this diagram only. So this is the cell of heart, the left ventricle. Can you see this cell, the yellow color cells I have drawn in the wall of the left ventricle? This is one of the cell. Okay, now at the time of the systole, what is happening? There is a calcium channel present on the, this is the cell membrane, the yellow color cell membrane. On the cell membrane, there is a calcium channel present. From the calcium, voltage sensitive calcium channel, a little bit of calcium is entering inside, maybe 1%. 1% of the calcium, a little bit calcium is entering inside. Voltage sensitive calcium channel, you can see. From the calcium channel, calcium is entering. After entering, it is going in the endoplasmic reticulum or sarcoplasmic reticulum of this cell, of this cardiac myocyte. This is sarcoplasmic reticulum or endoplasmic reticulum. It is having a receptor. It is having a receptor which is known as Renal receptor, RYR, Renal calcium channel. This 1% calcium is going there, 1% which is coming from outside and triggering it, and it contain abundant of calcium. This sarcoplasm, endoplasmic reticulum or sarcoplasmic reticulum contain abundant of calcium. As soon as this RYR get activated by small amount of calcium, it will secrete abundant calcium outside, the remaining 99%. So 1% is coming from outside, the remaining 99% is coming from sarcoplasmic reticulum. So total 100% calcium is there. Now once the total 100% calcium is there, it will go to troponin, and troponin will get activated and it will cause actin myosin to contract. Once the actin myosin contract, there is systole. There is systole in this cell. You understood how does the systole takes place? How does the systole take place? You understood or you didn't? I'm saying it again. See, at the time of the systole in the heart, a little bit of calcium, 1% of the calcium is coming from outside, from voltage sensitive calcium channel. Voltage sensitive calcium channel, this 1% systole is coming inside. 1% calcium is coming inside. This calcium is going to the endoplasmic reticulum or sarcoplasmic reticulum and activating the RYR, Renal receptor. Once the Renal receptor get activated, you can see the abundant of calcium is present in the endoplasmic reticulum or sarcoplasmic reticulum, and they all will come out, all the calcium. So remaining 99% is coming from here, 1% is coming from outside, total 100% calcium is there. It is activating the troponin. Troponin is causing actin myosin contraction. Once the contraction takes place, it's the systole. Now systole is done. We have to do the diastole. How does the diastole? After systole, as soon as the systole takes place, contraction takes place, Hannah, on the sarcoplasmic reticulum, there is one more receptor. One was RYR, that was secreting the calcium outside. One more is there, SERCA, SCRCA. This is known as SERCA. Sarcoplasmic endoplasmic reticulum calcium ATPase. Sarcoplasmic endoplasmic reticulum calcium ATPase receptor. Say it's SERCA. Don't learn the full form. It's SERCA. What SERCA will do? SERCA बोलेगा कि जितना RYR से बाहर आया उतना मुझे वापस दे दो. SERCA will say whatever calcium concentration came out from Renal, I will take it back. So whatever given by the RYR, the 99%. Please understand. Whatever given by RYR, the 99%, SERCA will take it back, the 99%. Hana, SERCA will take it back, 99. So contraction will be released. Now 1% is still present. 1% is still, that 1% ka hi khel hoga. 1% is still present. 1% came out inside from where? It came from the voltage sensitive calcium channel. The 99% came from Renal. Whatever came from the Renal, it go back to the endoplasmic reticulum via SERCA. Hana, so that 99 is balanced. Whatever came out, it go back. So whatever Renal has given, the SERCA have taken back. But 1% is still present inside this. 1%. Now this 1% will go to sodium calcium exchanger. It is known as NCX. NCX, sodium calcium exchanger and asking this transporter, requesting this transporter that I'm 1% left, rest all are gone. I want to go outside. Can you please allow me to go outside? It will say, yes, my name is sodium calcium exchanger. I will exchange calcium with the sodium. If you go outside, it's okay, you go outside. But in exchange of you, I will take the sodium inside. So this is sodium calcium exchanger. So it is taking the 1% calcium outside. The remaining 1% calcium will go out. It's okay. But instead of that, the 3 sodium will come. 3 sodium will come inside. What does the sodium will do inside? What does the sodium will do? This sodium will also go on to go outside only. This will go to next transporter. The next transporter is sodium potassium exchanger. Sodium potassium ATPase. A transporter. It will ask, I want to go outside. I just came inside to balance the calcium, but I do not want to remain inside. I want to go outside. So this sodium will go outside. In exchange of that, the potassium will come and the story is over. This is diastole. So whatever 100% calcium is balanced, 99% go back in the sarcoplasmic reticulum and 1% go outside. The story is over. How many of you got it? This is the complete story. The story is over. Now, let me tell you the mechanism of action of digitalis. What does the digitalis do? Digoxin or digitalis does here. Can I tell you the mechanism of action of digoxin or digitalis? Digoxin or digitalis inhibits sodium potassium ATPase channel. Sodium potassium ATPase channel is inhibited. Okay, that's it. You see, ma'am, what will happen? You start from the beginning. You start from the systole. You start from the beginning. At the time, whenever there is a wave of depolarization, this voltage sensitive calcium channel will open and 1% of the calcium will go inside. Like previous only, there is no change. It will go and stimulate the Renal receptor like previous only. The remaining 99% calcium will come from sarcoplasmic reticulum like previous only. This 100% calcium will cause the contraction, actin myosin contraction, and systole will occur. Systole will occur. Okay, now systole. Now the 99% is taken back by the circa. Like the previous only, there is no change. But 1% which is pending here. What will happen to this 1% now? You tell me. What will happen to this 1%? What will happen to this 1% calcium? This 1% calcium normally go to NCX and asking the NCX, can I go outside? Normally it is allowed to go, but this time NCX is saying no. Because if I allow you to go outside, you will go outside, but I have to take sodium inside. If I take sodium inside, normally sodium go outside with sodium potassium transporter, but now sodium potassium transporter is blocked by digoxin. So sodium potassium transporter is blocked, so sodium will not go outside. So I cannot take the sodium inside. So I cannot take you outside. So this 1% calcium will remain inside only. And this 1% calcium again go to RYR and stimulate RYR again and again, and again contraction occurs. So this is how systole is prolonged and intensified. And this is how it's an inotropic drug. At least I tried from the depth of my heart. But you people are quiet. No one is saying anything in the chat box. Say people, you got it or you didn't got it? You got it. What is the mechanism of action of digitalis? Or you want me to repeat it again? Shall I repeat it again? What does digitalis do? Digitalis inhibit this transporter, sodium potassium ATPase. What will happen now? Please say something, people. You got or you didn't got? Give a gesture. What will happen now? So whenever there is a wave of depolarization, the calcium channel will open. Voltage sensitive calcium channel. 1% calcium will enter from here to inside. This 1% calcium will go to RYR, stimulate the RYR. From the RYR, 99% calcium will come. So total 100% calcium will cause the contraction. Okay, now after contraction, this 99% is taken back by the circa, but 1% is still pending. This 1% go and ask the NCX, can I go inside? But NCX is not allowing. Because if it is going outside, the sodium is coming inside. Normally sodium leave by this transporter, but this transporter is blocked. So it is not going inside and it will remain here only, and it will again and again and again, it will cause the contraction. And that is how the systole become intensified. Again and again the systole is taking place. Systole is intensified of prolonged duration, of more contraction, of more force. And that's the mechanism of action of inotropic drug. Okay, so this is the mechanism of action. So what is the mechanism of action of digitalis? Digitalis is one of the inotropic drug. Say, ma'am, it blocks sodium potassium ATPase transporter. Read the story. So what does the digitalis do? Digitalis inhibits sodium potassium transporter present on the cardiac myocyte. So sodium cannot exit out. So intracellular concentration of sodium will rise. So NCX will not function. NCX will not take the calcium out because sodium is already high inside. Okay, so 1% calcium is trapped. 1% calcium is trapped inside the cell. It cannot go outside. पकड़ में आ गया वो बाहर नहीं जा सकता. So it will increase the further calcium 99% again and again from the sarcoplasmic reticulum via the RYR Renal receptor. And again it will bind to the troponin, actin myosin. Again and again contraction takes place, and this is the mechanism of action of inotropic drugs. Okay, got it. Can we go ahead? Okay. And CX is indirectly blocked, you can say. है ना? Not directly, but direct blockage is of sodium potassium ATPase. This is the direct blockage. So if you understood, it's very good. If you didn't understood, learn one line. What is the mechanism of action of digitalis? Learn one line. It inhibits sodium potassium ATPase block receptor. It transporter. It inhibits sodium potassium ATPase transporter. That's it. Learn one line. If you understood it in depth, it's very good. If you didn't understood it, learn it. Okay, so this is the complete thing I told you about the digitalis. Can we go ahead? So what is the use of the digitalis? There are two uses of digitalis. Number one, heart failure. Of course, it's an inotropic drug for the heart failure. And for arrhythmias also, it decreases the heartbeat. It increases, please understand, it's very tricky. Digitalis increases the force of contraction, but it decreases the heart rate. It is increasing the force of contraction, but it is decreasing the heart rate. Okay, it is decreasing the heart rate. Okay, so in arrhythmias it is used because it decreases the heart rate and causing the bradycardia. Okay, so you can learn like that. What are the adverse effects? There are two type of adverse effect for the digitalis: extracardiac and cardiac. Extracardiac mein most common, it stimulates the CTZ center in the brain. CTZ center is not surrounded by the blood-brain barrier. Na? It will stimulate the CTZ center and causing nausea, vomiting. So most common side effect is nausea, vomiting. And in the cardiac, it can produce almost every type of arrhythmia except Mobus type 2 and atrial flutter. It can produce the arrhythmias. Contraindication, you can learn. I'm having a mnemonic for you. The mnemonic is contraindicated in weak HEART, heart. C for carditis, that is myocarditis. I for increased calcium. W for WPW syndrome. H for hypokalemia and hypomagnesemia. Both are contraindication. E for elderly. A for AV block. R for renal failure, and T for thyroid. I know it's difficult, but if you see it once, it's easy. It's not very difficult. So we are done with the cardiac glycoside also. You know drugs, there is only one drug, digitalis. Digitalis is of two types, digoxin, digitoxin. Digitalis. Mechanism of action in one line. It inhibits sodium, potassium, ATPase transporter. Uses, there are two uses. Number one, congestive heart failure. Number two, arrhythmia. Adverse effect, there is a list of adverse effect I told you. And contraindication, you can learn contraindicated in weak HEART, heart. This is a mnemonic. Please learn that. Okay, got it. In the adverse effect, cardiac and extracardiac. And in the extracardiac, it's vomiting, nausea, and in the cardiac, it's arrhythmia. So that's the thing. This is how you have to make the master charts again and again and again. I insist people the same thing, master charts. Complete pharmacology in master charts. I cannot provide you. Someone was asking to provide bane banai ready-made. No, you have to do your homework. I have given you a view, a path. I have shown you how to do that, but I cannot give you, Hannah, the complete master charts. But I have told you now, for all the chapters I'm teaching you the one or two main drugs. The remaining you have to fill by yourself. So the master charts, this is how first you have to understand, because if I give you, it's of no use. I will write the mnemonic, you don't know the full form of the mnemonic, you don't understand the meaning behind that. I will write the mechanism of action just in one word. The use of master chart is only when once you have understood the column completely, and then you are just summarizing. Like for the diuretics I have done, here I am doing, Hannah. So if you have understood the column completely and just I'm writing in one line, only the first letter, only the mnemonic, you are understanding that. But bana banaya, agar if I don't teach you digitalis and give you this master chart, you say, ma'am, what is the CINHPT? What does it mean? Ma'am, what does it mean? Sodium, potassium, ATPase. You don't understand it. Once you understand it and then make it, then it's of use. Please understand my point. Okay, please understand my point. Got it? Why hypomagnesemia? Nikki wants to know. Okay, Nikki, I was not telling you this point. Let me tell you. Potassium, magnesium, both. So why hypokalemia also? You must ask this also, Nikki. Why hypokalemia? Why hypomagnesemia? I will tell you both. I will tell you both. Listen. What is the mechanism of action of digitalis? Nikki, you tell me. What's the mechanism of action? Say, ma'am, it is blocking sodium, potassium, ATPase transporter. Of course, that is the mechanism of action of digitalis. You must ask, key, how does it enter? It blocks the receptor after coming inside. Means it is present outside the cell, it cannot block it. No. First, it has to come digitalis. It has to come inside, and from inside it can block it. You are getting my point. You are getting my point. Digitalis cannot block this transporter from outside. It has to come inside the cell and then block it. So how it come inside the cell? The point is how it come inside the cell. How it come? It come inside the cell via this transporter only, है ना? जिस थाली में खाएंगे उसी में छेद करेंगे भाई, इसी को यूज करके अंदर आ जाओ और फिर इसी को मार डालो. You're getting my point. You're getting my point. Digitalis will come inside from this transporter only, and after coming inside, it kill this transporter only. So first it takes the use of this transporter to come inside, and then it kills this transporter. I mean inhibit this transporter. So how does it come inside? Normally, who is coming inside from this transporter? Have a look on this transporter. Concentrate on this transporter, sodium, potassium, ATPase. Normally sodium goes outside. 3 sodium goes outside. Look the arrow. 3 sodium goes outside and 2 potassium come inside. Normally sodium goes outside, potassium come inside, but normally potassium come inside, but now digitalis also want to come inside, है ना? So that it can inhibit this transporter, है ना? So there is a competition between the two. There is a competition between the potassium and digitalis. Who will go? Who will go inside? Potassium will go or digitalis? Only one of them can go at a time. At a time, only one of them can go. So who will go? Obviously the one who is more in concentration. The one who is more in concentration. So if potassium is less, imagine. So digitalis, more and more and more digitalis will enter inside. It will cause more and more and more contraction, more and more and more adverse effect. So adverse effect will be more if the hypokalemia is there. Hypokalemia, potassium concentration depends on magnesium as well as hypomagnesemia. You got the answer? Who was asking? Nikki, you got it? So hypokalemia and hypomagnesemia, where it is? Hypokalemia and hypomagnesemia both are contraindication. If the person already have hypokalemia or hypomagnesemia, person have more severe effects, and that can be the side effect. Okay, can we go? Okay, so we are done. So read the question, very easy question. Can you tell me the mechanism of action of the digitalis? What is the mechanism of action of digitalis? I guess the question is super simple. It inhibits sodium potassium ATPase pump, not sodium proton ATPase pump. No, sodium potassium ATPase pump, and via potassium wala point it is coming inside. So we are done with this also. Okay, so I think we are done with the CVS also. Now what all other units you want from my side? What all units you want from my side? We have covered the CVS also. We have covered the renal system also. We have covered the general pharmacology also. Now the main system you should revise before going to your exam, because it is a rapid revision. It's not a comprehensive course. Okay, you should revise as ANS, and antimicrobial is something you cannot skip. Antimicrobial and ANS, and maybe a small little bit about the respiratory system. It's a very small system, but usually you get the question on the anti-asthma drugs. So these are the important systems which are pending. Antimicrobial is a very big. It contains many units in that. The complete TB drugs, antifungal, antiviral, anti-malarial, protein synthesis inhibitors like the tetracycline, chloramphenicol, all the beta-lactams like penicillin, cephalosporin, monobactam, carbapenem, all the nucleic acid synthesis inhibitors like sulfonamides and trimethoprim and all that. So it's a very big unit. It contains multiple units inside that. Maybe more than 10 units are present inside that. It's a very big. But respi is small, ANS is small, and some other big small chapters are also there. Yes, anti-cancer is also there, but usually one question come from the anti-cancer, that too not certain that every year. But ANS every year. So I guess we need one more session. I will ask the team, because it is not yet scheduled, because we assume that we will cover it in 2 sessions, but we will do it one more session. I will ask the team when. I'm not sure. I will discuss with the team whenever there is a slot on the YouTube, we can do so, because you have back-to-back classes scheduled on the YouTube channel now. So we have to see where is the slot available. So whenever there is a slot available, wherever, I will schedule it soon, and you will get informed. I mean, you will get intimate. You have to see the YouTube channel, the same YouTube channel where you are watching it right now. Okay, so we will schedule one more session in which I will take mainly antimicrobials completely. It will take the major chunk. After that, autonomic nervous system, respiratory, and anti-cancer. Anything else you want my side? Anything else you want from my side? Kindly write down in the comment box. We can schedule it in the 3rd session. So thank you so much for being with me. I would like to end the session. Thank you so much for being with me. Thank you for your precious time, and wishing you all the best for your exam, whatever exams you are targeting. Just wishing you all the best. Thank you so much. I hope you enjoyed the session. So don't forget to like the session, give your comments, reviews in the comment box, and that's it. Okay, bye-bye. I'm ending the session. Can I end the session? Bye-bye. Okay. Got it. Okay, chal. Bye-bye. Thank you so much.